give a traction with the tube and ovary. Cutting the tube is also very easy. You just coagulate and tube. If ovary tube both are required, you put the clamp. This clamp has been put on the infundibulum pelvic after cutting the round ligament. And be very cautious about the bowel. So you put a sponge inside and push it bowel, and don't have a blind procedure. You see and apply that. Otherwise, there could be a risk of the bowel injury for that. That's very important. And this is a electrosurgical device having some localized heat. So therefore, I always sprinkle some water to cool down and keep it for some moments, then I will leave it. Otherwise, if I leave the hot tissues, it might touch the intestine, and that could be some problem for that. And therefore, Umial madam, I think salpingo-oophorectomy is very easy. With the left hand job of everybody, you can do it. It's not because you have to remove the ovary and tube, you have to cut it. I think don't do that. Now this is another case. I know that this is a case of dermoid cyst, bilateral dermoid cyst of 10 centimeter on both the ovaries. So I wanted to do it vaginally, and the patient also forced me. It's a paras lady also. I wanted to do it vaginally. Same procedure. You do it with that anteriorly a transverse incision, and that uterovesical fold of peritoneum. The posteriorly cut the bolt cut and enter into the POD, and then you go as usual. In a case of the hysterectomy, you do it, and then salpingo-oophorectomy, you can do it with the dermoid cyst also. So therefore, I am giving one example where the same thing has been there with the vessel seller on either side. You cut it, it went all, and then go up and deliver the uterus as usual. This is the uterine, second clamp is the uterine, and this side also first the uterovesical, the mechanoids and the uterosacral. Basic thing you remember, when the uterosacral is cut, you find the descent and all that, and that's the basic principle. We find the anatomy of the uterosacral. You cut it and then you can find it out for that. And now again, you go always try to go close to the uterus for that, both on the anterior, posterior and the lateral. You see the uterine, characteristically, clearly you can find a skeletonized. You don't have to skeletonize the uterine, but with the tissues you can identify that this is the uterine. Don't go more laterally for that. And don't be hasty in surgery. You go stepwise, one by one, and then do the procedure. And the last clamp, last part you deliver, I apply a clamp for the upper pedicle. Not for suturing, but if I put a clamp on either side, the whole uterus is delivered, and then the next adnexal procedure becomes much easier, and we get a lot of space for that. And this laterally procedures, you can have a temporary clamping to reduce the volume and allow us to see what is there inside. Now after that, I see clearly a dermoid cyst which is found, and then I give just drain the dermoid, come out, contents come out. As you could, the dermoid cyst content come out, the whole ovary can be removed for that. And the spillage to the peritoneal cavity is also not there for that. Nowadays nobody is also agreeing with the spillage, it can be done. And now the same procedure, you put a just round ligament one clamp and the infundibulum pelvic, this is the infundibulum pelvic, and then remove it absolutely clearly, all these procedures for that. And therefore this is a very easy procedure. It's not a difficult procedure for that, but the pre-op planning is important, pre-op diagnosis is important. The aorta, as Chinmay is rightly known, that aorta, the adnexal pathology, benign versus malignant, must be very, very clear for that, including the color Doppler and all that. And big myoma, big ovarian cyst. So this is another myoma, this is another, the other side dermoid, bilateral dermoid, again 10 centimeter each, we have planned it, we have diagnosed it, and it has almost come. And same procedure we can do it by reduction of the mass. And salpingo-oophorectomy in normal ovaries as well as in diseased ovaries is possible vaginally. That is my message which I can give you for that. Now lastly, Umial has told to show me some of the instruments. The very simple tools. A single-bladed speculum. Two speculum are important. One bulldog clamp, one myomectomy clamp, one Caesar, two clamps are important. Here these are devised a different clamp for the infundibulum pelvic. If you are not having a suture also, two clamps are, one is for uterine, another clamps, and one is a little curved one I have designed, just different from the Sirit sets clamps for that. And one suction evacuation, suction cannula, which has to be there with or without the fiber optic instrument. In a deep seated, we can use the fiber optic instrument for that also. And this is all designed, I've customized, it's already there, but I've customized and put it under vaginal hysterectomy set. one set. And this is very important. I have told that for gynecologists, don't take charge too much. If each instrument has to be bought, each instrument about 5 to 10,000 rupees. I show that customize it and give it a package with a list instrument, with the list price they must use it. And the skill must be propagated, science must be propagated for that. And therefore, this is a Tuft company which is manufacturing for me and customized for me in a pack he has given for that. So these are individual instruments for that. You can see the beautiful Caesar, you can use it for other purposes also. This is written PCM, my name has been inscribed there unnecessarily, I don't wanted that. This is a set, main purpose is to spread the science for that. And this Caesar can be utilized for other purpose. This clamp can be utilized for other purpose also. Because this is a clamp which you find that is a little curved. This is a curved, and the serrations are very, very important for that. And the serrations are there, it don't slip for that. So for the uterines and for the vital structures, it's very good for that. So another clamp, the other clamp is little more curved than this clamp, and which is very beneficial for the infundibular pelvic, number one, and most important for the upper pedicle. Upper pedicle, this clamp is very, very important. The curved clamp is very, very important for that. And they can serve the two purposes with the upper pedicle as well as with the infundibular pelvic for that. So these are a few instruments. We do not want more instruments for that. This is the instrument, classical modification, little modification from series set clamp. It is a longer, it is just not a short, longer, it is equivalent to the normal clamp with a little curvature. And this is important for that. And the serrations inside will have a very important thing that it won't slip. The curve usually there slips. Indian, I think we say that the follies, Ellis and Polis, these are the things which doesn't leave. But Indian follies ruptures, Indian Ellis slips, and Indian Polis slips. So this is a thing which needs a good quality instruments for that also. Otherwise, you are in a shoop during the middle of the surgery for that. So this is important. This in 10 sets they are giving it with a single, I think in a tray or autoclavable tray which can be auto. This is important. This is a suction device which acts as a suction as well as a retractor. I have also incorporated some fiber optic cable into it also. So that fiber optic cable, if you go it deeper, there is a bleeding, that will suck it, that will suck, that will retract, there will exposure, and then you can coagulate for that also. This is important for that, and that's a benefit of that. This cat's paw is and bulldog clamp is also important for the initial holding of the cervix as well as the debulking procedure for that. So these 10 instruments are customized for that, and along with that, with the single electrosurgical device, with the vessel sealer, whole procedures, a difficult hysterectomy can be handled very easily for that. And that's an important thing about the tools, basic tools and routine tools apart from electronic tools. And that I've designed that box, and in the box you can put it all these one by one. And this is a box which is there, a still box which you can put it, and it's autoclavable. You can do an autoclavable thing for that, and whole things you can have a setup in the autoclave and then do the procedure for that. And the other electronic gadgets, I have already shown you in the gadgets of this shear. The shear is a very good thing. It cuts it automatically. There are two types of sealing and cutting. One is a sealing and mechanical cut. You just press it and mechanical cut, I have already shown in Martin. But this Indian company have a sealing and cutting automatically, and that is helping much more, and that is now very helpful, that very economical, cost effective, and very easy also. Don't need to have another Caesar to handle it for that. And this is a hysterectomy set customized for that. That is available from the Tuft Surgical. It's a good set which I'm very happy that my disciples are using it all over and very satisfied about it, this for that. And the basic electronic thing, that electrosurgical device, you can use it. You can use the harmonic also, but harmonic becomes very costly, and routine change of the shears will have a very important thing, so that you can replace it. It can be replaced by the shear which is designed particularly for laparoscopy. It was there, and I have designed this particularly for the open thing. This is what I was telling about the innovations of putting a fiber optic thing along with that speculum on both sides. Initially it was on one side. I put it on proximally one side and distally another side. And this is the divorce which having that. That was there originally, it was there. But this doesn't help us much, excepting in a case of sacrospinous fixation it helps us. And the main thing is about the routine 4 mm suction with device. This is important. One side there is a light source and one side there is a suction. And this light in deeper tissues is much more important and facilitates the surgery for that. And this is all about the hand instruments, particularly in vaginal hysterectomy, which is very less. We don't need in the trolley a series of instruments for that. Apart from this instrument, at least 4 LEs is important. Good quality LEs is important. And this is what I mentioned, and I have used it, that this is particularly the shear and designed by the Alan, and it just PB also is designed now. PB and Alan are the two surgical instruments company who are manufacturing here in India, and that is very cost effective also. These are the tip, and this tip also the coagulates, and this tip also at the tip, the same current cuts it. And very, very good instruments for that. We can use it either, this is a Martin, which I have shown you. Martin has got, this is a very costly thing for that, but this doesn't have a cutting. This is only sealing, but that have a sealing as well as a cutting, which also an additional help for all these people and all the procedures for that. And this has to be connected to the machine, and every machine has a special design, and their companies people are very, very intelligent. They say that this doesn't fit with that and all that, and just a cable has to be changed for that. But now the Indian company, for the Martin company, you cannot use it for all. But the Indian company, the Indian instruments can be interchangeable for that. So these, earlier it was detachable, and now it have incorporated and make it hike the price for that. Earlier I was having detachable, only cable, one instruments, and that instrument I have used it 5,000 hysterectomy with one instruments also with that. Now they are not earning money out of it, recurring money, so they changed into with the cable with the one IQ instrument set, and that cost is increased for that. This is a mechanical cutter. There is a mechanical cutter. They don't have the shear concept, and this is vessel sealing with the cutting. You press it, the cut, mechanical blade cuts it for that. And this is of KLS Martin, and this is also good. Only thing is here is that it's the length of the jaw is less, and we wanted a long length, at least of 2.5 to 3 centimeter length, as I have shown you, and that's why I've increased the length and designed in the subsequent series for that. And that is yet to come to the market. They have not marketing that, and only for me they have prepared something, and I told that this is good, but provided the current cuts, it is more advantageous than the mechanical cutter for that. And that is the whole lot of the hand instruments which is there, which I will show you. And this is the machine, the CombiFlux machine, which has unipolar, bipolar, vessel sealing, and underwater cautery for that. And this is one machine which on request of Dr. Umayal, I am showing this for that. Thank you very much, ladies and few gentlemen, for giving me the opportunity and an extra time.
Thank you
Madam
so
Chairperson,
much.
I am obliged.
Thank you so much, sir. It was wonderful to see your instrument innovation and this thing. At the same time, the basics you told us, the tips and tricks, how to avoid the complications. Go closer, closer. You went on repeating it. And the right person, the right surgeon, the right decision. It's very, very important, apart from dissection. It was wonderful. It was a real treat for us to see all the videos. Wonderful, sir. Thank you so much.
Thank you so much, sir, for...
Thank you.
Another important thing you said, see and cut. Yes. That was a very good message.
Thank you, sir, for a wonderful and extensive sharing of knowledge about the vaginal hysterectomy in this session. And next, contrary to their topic, here now we welcome Dr. Priyankur Roy, who is going to deliver the speech on TLH in the era of cesarean section.
Dr. Priyankur Roy, Assistant Professor, Lord Buddha Koshi Medical College and Hospital, Saharsa, Consultant Infertility and Gynec Endoscopy, Roy's Clinic and Nova IVF Silguri, Chairperson, Elect Public Awareness, Foxy Vice President, Member Contraception Commission, FIGO, Member, Scientific Program Commission, FIGO World Congress 2023. MCM ISR National Joint Secretary of Silguri, OBG Society, IMA Silguri, and Gestosis India. Organizing Secretary of East Zone, UFOXY, International WATOC Conference 2021, invited faculty in many international and national conferences, including FIGO, FOXY, FOG, published more than 70 articles, various international and national journals, authored 25 chapters, editorial board and peer reviewer of various journals, including UGO, JOGI, etc. Awards, gold medal for topping in MS University examination, FOXY Korean Award, FOXY Future Award, AOFOG Sean S. Ratnam Young Gynecologist Award, FOXY Dr. Kamini Rao Orator, FOXY Dr. Shanti Yadav Award on Infertility, FOXY IAEC Sun Traveling Fellowship, FOXY Dr. Nimish or Shelat Research Award, FOXY Dr. Kubud Tamaskar Research Award. Over to you, Doctor. Please.
Good morning, everyone. First of all, I would say Nandri for having me here for this presentation. And it's a matter of pleasure for me to be standing in front of all of you today in this morning. I personally would like to, always wanted to come here to Kanchipuram Society and thank all of you for the support that you extended during the East Zone UFOXY conference. There were a lot of volunteers from the society, and I thank you all for helping us out during the East Zone UFOXY conference. I would like to thank Umail ma'am, Chakravarti sir again, and the organizing team for this opportunity. Now, before I start, I will start with a disclaimer. I have been sandwiched in between Dr. P.C. Mahapatra sir and Dr. M.C. Patel sir. Both of them are teachers, and I am a student still learning from them and from all of you. So do not expect my presentation to be that of a teacher. I will just be of a student, and I will be learning from you, and I will be taking more points home from all that you have to teach me today. So I would first of all like to thank all of you for your blessings and love in electing me unopposed as the chairperson of the Public Awareness Committee. And I am here to talk about TLH in the era of cesarean section. I had a few videos that I had put up for this presentation, but unfortunately did not work with my pen drive, and so I have remade my presentation, and we will go through this presentation in the next 20 minutes or so. So PC sir has already given a wonderful talk as always. We all love listening to him, learning from him always, and he always says this thing: challenges are what makes life interesting, and overcoming them is what makes life meaningful, is a famous quote by Joshua Marine. Accept what is, let go of what was, and have faith in what will be. So we were in an era where abdominal hysterectomies were something that was totally in, that was the only thing that we could do. We came in with vaginal hysterectomies, which were also, of course, done and still done, and it's, of course, one of the modalities which is a debate which is better. And then we are now into laparoscopic hysterectomy era, and also probably some bit of V-nodes that have also come in nowadays. So why talk of laparoscopic hysterectomy? It's associated clearly with relatively less blood loss, shorter hospital stay, speedier return to normal activities, the daycare surgery concept that has come in quite advently nowadays, better cosmesis and patient acceptance, and fewer abdominal wall infections when compared to abdominal hysterectomies. The vaginal approach, of course, is less expensive, may be challenging for patients with adnexal masses, but not challenging when you have a surgeon like Dr. P.C. Mahapatra sir operating, because in his hand, everything is very, very simple. Endometriosis, pelvic pain and prior abdominal surgery, and in patients with a narrow pubic arch or poor vaginal descent. So life is a matter of choices, and every choice you make makes you, was said by John Maxwell. And that sounds very apt for all of us, because we have to decide for our patients, with of course counseling the patient and taking a proper consent from them, whether we want to go for a vaginal hysterectomy, abdominal hysterectomy, or laparoscopic hysterectomy. So the topic given to me about laparoscopic hysterectomy in this era of previous cesarean section. I'm sure there are a lot of juniors present over here, a lot of postgraduates present over here who are aspiring to become laparoscopic surgeons. I haven't changed any of my slides based on only cesarean section, because of the fact the number of cesarean sections we have done in the last 5 to 10 years will increase, of course, the chances of TLS that we have to do in patients with prior cesarean section. So that is going to be the new normal for us. Maybe in the next 3 to 4 years, we will not get patients to operate on who did not undergo a cesarean section before, because of the fact that we have done cesarean sections over the last 5 to 10 years has been immense. Also understanding the fact that when we started off our practice, we had lesser complications, and I'm sure in the next 5 to 10 years in operating in cases of previous CS, we might land up in complications in 1 or 2 cases sometimes, because of the fact that we'll be operating on the new normal, that is TLH in a case of previous cesarean section. Now, important things to note in this are basics. I will talk of all the basics step by step. So first of all, positioning of the patient. The patient is placed in a Trendelenburg position for better access to pelvic organs. The patient's arms are tucked in. The patient's legs are flexed at the hip and knee joint and placed in stirrups using caution to prevent compression on the lateral cuff and thus peroneal nerve damage. Now, in these 3 points that we see over here, number 1 point, the Trendelenburg position is quite important. Have an OT table which will give you maximum head low, and have an anesthetist who will allow you maximum head low. Usually in our OTs, what we see when we have an anesthetist and we tell, can we have some more head low? They will go up to maximum of 20 to 30 degrees and they'll be like, ideda panna muriyo, idukku mele onnu panna muriyadu. So do not have an anesthetist of that sort. Have someone who is your friend. I'm sure many of you here will have your husbands who are anesthetists as well, but prefer someone who will give you more head low, because that will help you in your surgery. Second point, have the arms of the patient tucked in beside the patient, in the sheath, because that makes your work very much easier. There are a lot of anesthetists who wants to give a hyperextended arm position, which is not something that is preferable. You will have to have an extra 100 centimeter extension for the IV cannula that you have put, and that's all will be required when you're using this tucking in of the arm method. It makes work very easy for you. Third thing, of course, stirrups. And please remember, when you have put in your stirrups, you put the patient's leg there, put a padding in between the leg and the stirrup, because there can be compression of the peroneal nerve that will lead to foot drop. You are doing a TLH, you are going to be there to answer to complications like bowel, bladder damage. I am sure none of you will want to answer a complication of foot drop, because we do not understand what foot drop is. You will have to call your physiotherapist, orthopedician, and a lot of other things. So make sure when the patient is positioned, please stand by the leg end of the patient. Make sure you have positioned the patient as per your comfort, because that is when the surgery will be much, much easier for you. Second thing, the OT setup. Now, I remember a very famous line which was said by Dr. Prashant Mangeshikar. He said, when you are starting your practice in laparoscopy, do not buy a Mercedes, buy a good OT setup. Because you are going to spend most time in your OT and very less time in your Mercedes. Because that is what you want. You want to spend more time in your OT. So get a OT setup which will help you to do your procedures well. Get a setup which will make you attracted to the OT, so that you stay in the OT more and not in your Mercedes more. So OT setup is very, very important. Get instruments which makes things very comfortable for you. Your visibility is very good, because in a case of previous cesarean section, if your visibility is not good, there are high chances of you ending up with complications. So as I've mentioned, OT setup, there could be 2 or 3 things that we can look of. Number 1 that we can look of is, of course, when we are operating the screen. There is in some of the OT setups that we go, especially in smaller nursing homes or hospitals, you have only one TV screen. So you have an assistant who is sitting at the foot end of the patient. You are standing on the left side of the patient, and you have an assistant on the right hand of the patient. Now, how do you expect one screen which will fit all 3 of you? You will need a wide angle LED, probably a 40 or 50 inch screen, which will cost you very much. So it's better to have 2 or 3 screens, which at least one for yourself and your assistant who's sitting at the vaginal end, and maybe the other one who's standing on the right hand of the side. Because understand that only you seeing will not make your surgery easy. All 3 of you will have to see it well, then only the surgery will become easy. Because otherwise the assistant will not know what they're doing. They will not know what you have to show. And if the assistant has to turn the neck to 180 degree at the back and then show you one case, definitely it's going to make surgery difficult for you. So anatomy, of course, is the same anatomy that we have, except for a few modifications. Maybe the bladder will be stuck in the anterior wall of the uterus. There may be some bit of deviation, maybe some bit of the ureter deviation that could be present in case the retroperitoneum was opened. And otherwise, if you look at, there could be some addition of the omentum to the anterior abdominal wall. And other than that, mostly the anatomy will be similar to what it is in a normal TLH case. It's very important for us to understand and know the retroperitoneum. So for all the aspiring laparoscopic surgeons, please be very good with your anatomy, with your open surgeries first, and then try to learn laparoscopy, because that makes things easier. When I started, I thought I learned laparoscopy first, who cares about open surgeries? But that is not how it is. Now I realize that once you're good with your open surgeries, when you're good with your retroperitoneum, you will not have that added tension, you will not have that added bit of worry or of fear that even Mahapatra sir was talking about. You will not have that fear. What will happen in the ureter open aitcha enak theriyala, ureter cut pannitana theriyala enak, that confusions will not be there. Because if you are good with your retroperitoneum, you can check it for yourself without any, you do not have to depend on your urologist or other doctors to come to your OT and wait for them to come and then do it accordingly. So retroperitoneum, but again, important point over here, nowadays I see most of us, the younger generation surgeons, open up the retroperitoneum in most cases of TLH, and they say that the clamping of the uterine artery at the origin is something that may be required. But believe me, it is not required. You can go ahead with a normal TLH. Hugging close to the uterus is what everyone says. Keep hugging close to the uterus and continue doing. But retroperitoneal dissection you should know, because that will make life easier for you. Ureter, the normal course we know, we need to know it at where it enters the bifurcation of the common iliac artery. To be remembered, in the female, the ureter passes above the lateral fornix of the vagina, lateral to the supravaginal portion of the cervix, and lies below the broad ligament and the uterine vessels. The first point is most important, lateral fornix of the vagina, and especially when you're dealing in a case of cesarean section, this might be pulled a little bit towards the uterus, little towards the medial part, and that will make things a little difficult for you. So you will have to take appropriate steps so that the ureter falls away and you do not clamp or you do not cut the ureter by any way. So this is what your ureter probably will look on a laparoscopic view, and a retroperitoneal dissection looks quite easy in this case, and it's actually quite easy. Only thing is you'll have to know that basic steps when you require to do it, and not regularly in all cases. So let us do this step by step. I have another 10 minutes, so we will quickly finish it off, and we will see all the steps together and how to go ahead in these cases. So the important steps: insert a Veres needle into the peritoneal cavity. The tip, an easy way to confirm intraperitoneal entry is to look for negative or low pressure reading on the insufflator if you have already attached it to it. Use the Palmer's point, left subcostal mid-clavicular line perpendicular to the skin. Stomach should be emptied. Rule out any hepatosplenomegaly for obese patients, patients with previous abdominal surgeries, including cesarean section. So, one of the important key steps, initially when you put in a Veres needle, please do not go anywhere near to the previous cesarean scar if it's a midline incision. Number 2, stay away from it, at least 2 to 3 centimeters away above the umbilicus in case it has been a previous cesarean with a midline scar. Second important point where we can go is the Palmer's point, because at this point there will be no chances of adhesion, and it will make things quite very simple for us. The other test that we can do is also called the Palmer's test, in which we put in water through the syringe into the Veres needle, and if the water passes on very easily into the peritoneal cavity, that means we are into the intraperitoneal space. Now, this is the pressure points that I wanted you all to make a note of. Number 1, this is while you're doing a laparoscopic surgery. Set your pressure at 14 millimeters of mercury and a set flow of 10 liters per minute. The one picture on the down is of a picture when you have put in a Viris needle. This is approximately 12 millimeters of mercury is the set pressure, and the set flow is 6 liters per minute. Remember, in a Viris needle, it's only 2 to 4 liters of gas that can flow through. You can keep it at a maximum level of 6 so that the flow is optimal and you do not waste much of your time. If you put it at 10 to 12 at that point of time, you are losing your gas because it will leak out from there and it cannot go in and that sort of a pressure. So it's not required for you to do that. It also causes damage to the valve of the Viris needle. So do not put it at a high pressure when you're putting in a Viris needle. Now, port placements, the most important step. Initially, when we start off with our training process, we are initially given to put in the secondary ports, and the day we get our primary port, we used to give a treat to the unit or to the department. Now, port placement for me still is the most important step, and that step is deciding where you will put a port makes your surgery so much easier. Because if your ports are wrongly placed, remember, putting a cesarean section incision quite high up, it will make things difficult for you. Similarly, in a total laparoscopic hysterectomy, if the ports are not properly placed, it is not placed in the pattern in which you are comfortable in, it will make things difficult for you. So the usual thing is a supraumbilical port, and you put 2 ports on your side because you will have 2 instruments on your side, and 1 port on the contralateral side where your assistant will help you out with using this instruments. So this is how the normal port placement is. It's in a, as you can see over here, it is in an inverted C shape, or you can say in a baseball pattern. So basically the supraumbilical port, 2 side ports on your side, and you can have 1 port on the contralateral side, which will be for the sake of the assistant. Now, once the intraperitoneal pressure has reached to set 14 millimeters of mercury, insert the 10 mm umbilical or the supraumbilical trocar. Complete survey of the abdomen to rule out any visceral injury at the time of Viris or trocar entry. So, the important point over here is, after you have put in your primary trocar, you put in a secondary trocar from the other side. So, basically what happens is, we put in a primary trocar, we put in a camera, inspect the entire abdomen. Then with the help of the visualization, we put in the second trocar on the left side. With this second trocar, which is usually a 5 mm trocar, you can go in with another 5 mm camera and see whether the primary port has caused any injury. Please do this because that inspection is very, very important. There are many times in case of previous cesarean section cases where we go through the momentum, do not realize it at that point of time, and later on end up with complications. So it's important for us to inspect the primary port site as well, whether we have gone through any viscera, whether we have gone through any structure, or at least we have gone through the omentum also. Now, this is for routine inspection of the structures. Depends on what you use for elevation, whether you use a uterine elevator or a manipulator, or you use a myoma screw for your cases. So this is a case in which it is using a myoma screw, which I routinely do in my practice, and it depends on how you have learnt it, where you have learnt it from, and what your teacher has taught you. Based on that, you can take a call on how you want to go ahead. So in my clinic, we routinely use the myoma screw for uterine manipulation during TLH. Others, you can use a uterine manipulator, elevator, or a uterine hitch. Remember, where you should not use a uterine manipulator, 2 situations. One, in case of an endometrial cancer where peritoneal spread of the tumor is feared. Number 2, in case of, where you're thinking in case of pyometra, where there could be a cervical cancer and insertion of the screw would lead to spillage of pus into the abdominal cavity. So 2 considerations, one for myoma screw and one for a vaginal insert. So vaginal insert is not to be done in case of endometrial cancer, and a myoma screw is not to be done when you're using in case, especially in case of a pyometra where you might spill the pus into the abdominal cavity. Now, things that you need to inspect: ureter at the pelvic brim, the infundibular pelvic ligament, and the utero-ovarian ligament. If it's a simple hysterectomy, we do not need to do anything of this sort. But when we are talking of in a case of in case of previous cesarean section, we definitely need to know where the ureter is so that we do not end up in complications or we do not lead to any injury to the ureteric structure. So the ligaments are coagulated and incised with a combination of vessel sealing and ultrasonic scalpel, as perfect hemostasis would be key to daycare surgery. So I learned in a setup in Ahmedabad with Dr. Vineet Mishra sir in IKDRC. We started off with using bipolar and scissors only. So, and in his setup, we also had a harmonic Of course, it was a OR1 of a stores. In case if you know what a OR1 is, it's basically all the instruments of stores that are there in that OT, and with attachment of the software, etc. So with a harmonic and a bipolar, things are very, very simple. But remember, when you're starting a practice in your own nursing home and your own clinic, you need to also balance out the finances that you need to think of. Because a harmonic scalpel is not difficult for you to buy a harmonic generator. It probably will cost you 10 lakhs of rupees only. But the thing is, it's using the hand instruments is what matters. Each hand instrument, hand piece in today's day costs you 40,000 rupees. And they say it's to be used for one patient only. It's a disposable instrument. So if you're using a 40,000 instrument for harmonic alone, then how much extra will you have to charge your patient, and whether your patient will pay you, that is something that you need to think of. Second thing, you can use it for a number of cases, that's what is normally said, but also we need to understand once the white sheath that is there near the active blade is gone, that instrument is useless and you cannot use it anymore. So we need to balance that out as well when you're buying your instruments, and you need to think which is better. So for me, bipolar is definitely better. Along with bipolar is a must, so there's no question of better or not better, it's a must. Along with that, the other instrument that you can keep is a one which is not a disposable instrument, probably a shearer or probably other ultrasonic energies which will allow you to use the instrument over and over again. So looking at the desiccation of the uterovarian ligament, I think it's 2 more minutes, right? Yeah. So the rule is hug the ovary, that is, stay as close as the ovary as possible, use a bipolar current, and then you can cut it off with a scissor. So this is a must to prevent hemostasis. Dissection around the round ligament. Similarly, in a round ligament, an additional step I would say, which sometimes we do not do, but should be done in a case of previous caesarean section, is transect the round ligament and separate the anterior and posterior leaves of the broad ligament. In this, what will happen? The ureter will fall away. So the chances of you complicating or you cutting the ureter or you clamping the ureter is much, much less. So just by separating the leaves of the broad ligament, this step, it becomes so much easier. Anyways, we separate the broad ligament when we go down near the uterosacral. But if you do it at the beginning, the ureter just falls away without causing much of a complication for you. Find the correct plane. This is where the peritoneum separates easily with gentle manipulation. If you see this picture, you can see I'm operating over here, but the uterus is pulled to one side. This pull is the most important thing, the traction and the counter traction, because once you've given a good counter traction, the uterus just moves away, and that makes dissection very, very easy for you. The loose areolar tissue just falls away, and you can just easily cut and you can go down without much of a problem or complication. So immediately after the round ligament is incised, the uterus on the myoma screw, as I've said, the traction, counter traction mechanism is done. This elevates the uterine arteries along the lower cervix away from the ureters. The parametrial venous plexuses between the ovarian and the round ligament is coagulated with vessel sealer and divided using harmonic scalpel if you have one, if not, whatever energy source that you may have. Now, UV fold. This is an important step when you talk of previous caesarean section. Mahapatra sir has already talked about it, and we need to use the lateral window. So you can see over here the dissection is towards the lateral side and not at the center. Because the more the chances of caesarean section, whether it's a 2 caesarean, 3 caesarean, you need to operate laterally. You need to stay laterally, open the window laterally, you find your plane, and then go under that and go and cut. So it's important. You can use your scissors and a bipolar for these cases, or also use a harmonic in case you have it, using probably the active blade, which will make dissection very, very easy for you. So stay in the loose areolar tissue plane. Always remember, fat belongs to the bladder, so do not go somewhere near to the bladder, somewhere near to the fat. The second thing is, when you are dissecting it, stay parallel to the structure, stay perpendicular to the structure. Do not go in a tissue where you are parallel to the structure, because cutting of the fibers is much, much easier. Second, when you are cutting the bladder, when you're dissecting the bladder, you need to look for any air or blood in the urobag. Tell someone to have a look. In case if you find something suspicious, definitely you tell the assistant to look into the urobag whether there is any blood or any other structures over there. So after the dissection probably of the bladder, you will have a panoramic view where you have cut both till the uterine artery, and you have dissected the bladder away as well. And then after that, we will proceed further. So now securing the uterine vessels, it's easier said than done. It's very, very important. Remember, even if you have a harmonic, even if you whatever instrument you have, use your bipolar at this point of time. Do not miss using your bipolar. And what I usually do, and I was taught by my teachers as well, bipolar at 3 points, 0.1, 0.2, and 0.3, and then cut with your whatever energy source or scissor you're using at 0.2. Because clamping it or coagulating it at the first and the medial and the lateral end and cutting in the middle decreases the chances of blood flow. And remember, when you're doing a surgery for adenomyosis or a fibroid uterus, the blood flow to the uterus is higher. And even if you cut after like you have coagulated laterally and you have cut medially, the backflow from the uterus itself will make the field messy and it becomes difficult for you to operate. So always do the 1, 2, 3 mechanism, cut at point 2, that is the center, and that will make the field bloodless and it will be easier for you to operate. It is important to take the uterine vessels high and then dissect medially to the uterine vessels down to the cup. It avoids ureteral injury, as has been said, and please use the traction counter-traction mechanism in this case because it makes things easier for us. The Jodi is very nice, that is the vessel sealer and the harmonic, but the Jodi is not nice for us financially because it costs a lot of money. You will have to use your disposable instruments, which again will have to be used with caution, and of course you will have to, after explaining to the patient the cost factor, etc. So how you use it? I usually use it on my side. So harmonic, especially I keep the harmonic on my right hand, and I have my vessels on my bipolar on my left hand. So with my bipolar, I keep going and I keep cutting with the harmonic. It makes things easier. If I do not have the harmonic in that case, I can have my scissor. So bipolar on the left hand where I can keep coagulating, and my scissor on the right hand where I can continue cutting. Now settings of the harmonic, in case if you have one, again, 1 and 5. Whenever you're doing something to your blood vessels, do not keep your setting more than 1 for the minimum. And always use the minimum current to the maximum time possible. And when you're doing a blood vessel, dissecting a blood vessel, do not use the maximum current. Because minimum will coagulate it and then cut it further. That decreases the chances of blood loss further. Separate the uterus and the cervix from the vaginal apex, of course. We'll do this. We'll cut it with, you can cut it with a bipolar scissor, also the active blade of the harmonic, and that will be dissected easily. And finally, when you have started off with your colpotomy, you can see this picture. You can see the cup in case you're using a cup, and you can dissect off the uterus. Pull the uterus into the vagina. Take care of the bladder and rectum. You need to see whether it's complete. There is no bit of complication or no bit of trauma to any of the structures that are present. Delivery of the organ, of course, vaginally is much easier. If it's a bigger organ, there are 2 things that you can think of. One is coring the organ, or also you can do morcellation and take it off. Now, to do morcellation and not to do morcellation is a separate debate, and I'm not coming to that in this, or it's not in the scope of this presentation. Now take the specimen out, bring the suture through the vagina or also through the port, whichever you find comfortable, and then you can suture up the vagina laparoscopically. The pelvis is irrigated and hemostasis at all suture sites is noted. Remember, this is a very important step, that hemostasis has to be noted very well. Because until and unless the hemostasis is noted well, even if you put in a drain, you might end up with some bit of bleeding that might come and unnecessary tension that you may have. Post-operative management, monitoring for recurrent intra-abdominal and retroperitoneal bleeding is something we have to look at. Note, early ambulation and compression devices can be used to prevent thromboembolic complications, and now in this era of daycare surgeries, we usually discharge them on the same day evening or maximum next day morning. Continuous monitoring of vitals definitely is a need, and in case of any blood transfusion, they might be needed to be admitted in the ICU. So if the risk is high, the reward is high, why not roll the dice? So if a case of a previous cesarean section where we were scared previously, where we used to think we'll do an open surgery, but then TLH definitely with practice comes in and it makes things so much easier for the patient as well as for us. So the important things to note, just to summarize, omental adhesions to release using bipolar or harmonic scalpel. Timer, okay, this one. Lateral window avoids dense bladder adhesions at the center. Sharp dissection, better to use scissors. Methylene blue to test the bladder integrity, or you can do a cystoscopic evaluation as well to see for any injury to the bladder. And proper counseling, look for possible injuries. Know when to abandon or call for help. Do not, as sir was also saying, no ego in this. You can call your senior person along with you, or you can abandon and go to an abdominal surgery. I have my medical legal guru over here, Dr. MC Patel sir, and this slide is taken from him. Something that I do not do, eat less and walk more. We need to be doing necessary stuff and talk more, which I'm sure all of us do. We work a lot, but we do not write much. So documentation is something that we need to stress on. We need to counsel a patient well, and we need to document a patient even better. And what is important is, whatever you have taken a consent, do only that procedure until and unless it's a life-saving procedure. Do not do anything extra for a patient until and unless that consent is not taken. This is a scene from the movie Badhai Ho. It's very, very important for us not to be surprised. This was a surprise scene where everyone got surprised when this 40-year-old woman got pregnant. So in our case, it's very important for us to plan our surgery, know what could be the complication, what is the pathology, and take it up forward from there, and not plan intraoperatively only without knowing what is in store for us. Thank you so much once again for this opportunity, and thank you for that extra bit of couple of minutes that you gave me. Thank you.
Thank you, Doctor, for a clear and elaborate presentation. Thank you.
Thank you so much, ma'am.
Thank you, sir. I would like to invite Dr. MC Patel to give a talk on the mob violence, how to prevent and protect the need of the hour.
Yeah, it's my privilege to introduce Dr. Patel MC. He's a consultant obstetrician and medical legal counselor, Vice President Foxy 2018, Organizing Secretary ASUOG 2017. He's a chairperson Ethics and Medical Legal Committee, and Honorary Secretary for State Organization of Gynecology and Obstetrics at Gujarat, Organizing Chairperson of MMCon, and President Ahmedabad OB-GYN Society. Over to you, sir.
Thank you, ma'am. Unity, tallest statue of world, and we all are proud of that statue. And so I invite to visit that statue this year only on 9th, 10th and 11th December. We are going to host our state organizations of Gujarat conference. Of course, Ahmedabad is doing, but it is destination conference in Statue of Unity. You are most welcome to get registered for that conference. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Kanchipuram OB-GYN Society and Dr. Chakravarti sir and Dr. Umayal in particular for inviting me to share my views about the subject. So since morning we are discussing clinical aspect, and let us see non-clinical, but how it is important and relevant in our day-to-day practice. So is it worth discussing any of my medical legal talk? I start with this question. So, and one more question, is violence against doctor in India a problem which is so big as to require a public debate? Yes, and if it is yes, then why? So story of Medipoint Hospital, which happened in city of Pune only, 27 years old boy, known case of RHD, was brought dead in this particular hospital, and medical officer on duty declared he was dead. So as soon as he declared he was dead, more than 100 people gathered in the hospital, and ransacking of hospital was done like this within no time. And this is happened in one more city of Maharashtra only, city of Nanded, and our Foxian friends were beaten very cruelly in one other case. As far as this gentleman is concerned, Seju Kumar, resident doctor, was on COVID duty in state of Assam and on duty when patient expired, and he was beaten like this very badly. So this is very important situation many a times. Say this is very real happen in city of Bharuch only, state of Gujarat, and this way doctor was beaten by a relative of patient. And same way in this case also, and in our own state of Tamil Nadu, so in this case also, this is also a real case happened in city of, one city of Gujarat only, and doctor was beaten like this in one of the cases. So in Tamil Nadu also we all know T. Setulakshmi in Tuticorin was murdered by a relative of diseased patient. So this is very common scenario, and now this is the reality in our practice. In MD examination of medicine, there was short note, violence against doctor, causes, effects and solution. It was short notes of 15 marks. So now this is scenario in our day-to-day practice. So in this type of situation, we are tense, how to manage, how to counsel, how to defend mob violence. So is violence against doctor unique to India? So there was study in WHO in 2014, and WHO received report of 372 such attacks in 32 countries, resulting in 603 deaths and 958 injuries. So it is not prevalent only in India. So what are the types of violence? It is not simple physical mishandling only. Telephonic threat, intimidation, oral abuse, physical but non-injurious, causing injury simple or grievous, murder, vandalism or arson. And who is at risk? It is long list on any duty doctors, housemen, CMO, consultant, super specialists, pathologists, radiologists, sonologists, sisters, ward boy, receptionists. In short, any healthcare provider is at risk as far as this type of incidents are concerned. And what drives a mob to a violence? Many times what happens, adverse outcome, and when we communicate this mortality or any bad news to the relative, then knee-jerk reaction is expected, and problems slowly gets initiated when other relatives enter in the scene and start asking barrage of questions. The same questions are asked again and again by different relative, and at one point of time, doctor's reaction, doctor may be irritated, giving answer to all the relative one by one in the same fashion. And many a times, problem starts further building up when mob start gathering, distant relative, neighbors, local leaders, dissatisfied old clients. And, many a times for no reason people also involved in this type of problems and vote banks politics. And problem gets flare up and sudden vandalism begins when one person calls loudly, maar dalo, tod dalo, and it becomes aggravated in this type of situation. And many times this could be the coexisting factors: intoxication, mental illness, irritation due to prolonged waiting, lack of communication, and political influence. So there was one study. In 2.4% are real fighters, destructive or verbally or physically aggressive, impulsive, antisocial, sensational. 4.7% are agitators. 26.2% will try to intervene to stop the violence. 61.1% will stand idly and watch the violence, and 5.6% will leave the venue. So this was study in mob violence incidences. Are the doctors are never at fault? It is not like this. But there are remedies in this type of situation. Patient or relative may go for civil suits in consumer forum or in civil court. Compensation can be claimed under Article 32. Complaint filed against medical council or National Medical Commission. Criminal cases in police station or in district court. Complaint can be made to the employer when doctor is working in one big hospital. Complaint can be made in Human Rights Commission to appropriate authority in Clinical Establishment Act, where it is prevalent in few of the states. So there are remedies. So mob violence is not the only way to tackle. So what could be effect of violence? So minor physical injury, serious physical injury, temporary permanent physical disability, psychological trauma, or in few of the incidents, death of doctor. Also, many times depression, insomnia, post-traumatic stress disorder, agoraphobia, and even a level of fear and anxiety causing work absenteeism. So this is the effects as far as violence, mob violence is concerned. And violence against doctor disrupts the working establishment, which lead to transient substandard care to other patients, which can have disastrous consequences to those patients who are innocent otherwise in this type of situation. And similarly, when doctor is assaulted on duty, he is prevented forcibly from providing continuous treatment to his other patients which are innocent in other cases. And in remote area, when doctor is working alone, and when this type of situations happens, then they are afraid to work in remote area. And already we are lacking as far as medical services are concerned in remote area. And when this type of incidents happens, then it becomes difficult for doctors to work in this type of situation. And many times qualified MBBS doctor and specialists are already desperately short in number. And then in this type of situation, they prefer to go to other country as far as services are concerned. Loss of eye or death of a doctor from violence are also noted in so many of the incidents. And why this happened? What are the reasons for increasing violence against medical fraternity in India? So we will never question our politicians when something goes wrong. When they never hit corrupt babus, corrupt businessmen, rapists, child molesters, bad drivers, bad administration, terrorists. But we doctors are very soft targets, and we Indians are the ones who only hits the doctor. Go to other country and think of hitting doctors will end up you in a very serious punishment. And as far as intolerance on part of society, we know, and social attitude is getting changed in this type of situation. एक अच्छा डॉक्टर केवल वही है जो परिवार त्याग कर कंद मूल पर जीवन व्यापन करे, मुफ्त इलाज करे और भिक्षाटन करके दवाइयाँ एकत्रित करे, बाकी सब डकैत माने जाएंगे. So this is the attitude of society changing as far as our medical part is concerned. This is picture of Lord Dhanvantari, first physician on earth. So previously we doctors were considered next to God, but now scenario is changed. Vaidyaraja namostubhyam, Yamaraja sahodara, Yam harati pranani, Tvam pranani cha dhanani cha. So this is the attitude of society towards medical fraternity. And see, bad roads, accident, patient dies in hospital, let us hit doctor. Bad food item, food poisoning, patient dies in hospital, let us hit doctor. Bad habits, heart and liver problems, patient dies in hospital, let us hit doctor. Bad trains, accident, patient dies in hospital, let us hit doctor. Dirty city, dengue, child dies in hospital, let us hit doctor. Dirty air, asthma, child dies in hospital, let us hit doctor. Bad government health infrastructure, complicated cases, child dies in hospital, let us hit doctor. No money, but doctor should serve free, otherwise let us hit doctor. So this is the attitude of society changing day by day. Many times role of newspaper media is also very much responsible, because see, this gentleman is enjoying this Jula, but how media will put it in this way. So this is the problem as far as media towards medical fraternity is concerned. And hence we tend to accept that the illiterate, poor and those belonging to a particular caste or community are culprits in mob violence, but it is not like this, because several WhatsApp videos have proved that even so-called literates, rich and higher class are also involved in such vandalism. So there is no class specific as far as these problems are concerned. And role of media papers. In KGMU, Lucknow University, long back in 2015, there were big news that during other surgery, doctors are stealing kidney. As such, in those days, even in Lucknow also, there was no surgery as far as kidney transplantation is required. So this type of news, very casually written, make a bad impression as far as our fraternity is concerned. So these are the problem. पैसों के लालच में सिजेरियन कर रहे निजी अस्पताल. So this type of news is in newspaper makes our reputation bad in hospital. Low care, health literacy, mob mentality, and lack of faith in judicial system and police to address genuine grievances. If at all there is grievance against doctor, people have no faith in judicial system and they will take law in their hand. So complete faith in police and judiciary to escape punishment if at all they go for violence against doctor. Poor image of medical profession and rising healthcare cost is also one of the cause in this type of situation. And poor budgetary allocation to the health delivery system, and particularly in government setup, in this type of heavy OPD or so, they will have built dissatisfaction on part of treating doctor. So prolonged waiting. These are some points which provokes as far as attacks on medical professions are concerned. So this is real pictures. She had a fracture and orthopedic surgeon was available on first floor and lift was not working. So this type of incidents many times build up against idea against our medical professions. And workplace violence. Violence often take place during time of high activity, interaction with patients such as admission and in emergency ward, patient transportation, patient in involuntary admitted, billing, hospital rules. So these are the certain situations where this type of incidents can happen. Is there a political nexus? Many times political party may also involve because they are interested to demonstrate their clout in this type of situation. There are some other causes also, but due to paucity of time, I do not go into detail. So in this type of situation, how to manage this type of situation, how to prevent, what can medical profession and institution do to prevent violence against doctors? First rule, do not panic. Of course, it is easy to say in this type of lecture, but very difficult to not to be panic in this type of situation. So tips to prevent and handle the situation pre. So mob violence not happen. So before that, how we can prevent it during mob violence and post violence. So as far as pre-part is concerned, when we are dealing with a very serious patient, make a habit to explain everything to the relative of patient time by time, because they should be mentally prepared to face any bad news in future. So whenever there is an adverse outcome, should face the situation or to run away? Many a time this question is asked, and many a times advice given from the stage, then we should face the situation. Of course we have to face the situation, but if life of doctor is in danger, then not to face, best way to abscond and abscond to the police station, not anywhere else. Because when you abscond anywhere else, then it will give a bad impression. And if you go to police station, then rest of the part will be taken care by police. So it is easy to say, do not run away. But however, what is my life or life of my family is in danger, naturally we have to run away. So what to do and how to manage? So role of rush team. So each society should have rush team, because in emergency, we may call it emergency squad also. So in emergency, member of rush teams are available to rescue of any of our friends in need. Because in this particular case, when there was some bad news, it happened in one of the casualty in government hospital, and there was gathering of relative of the patient. But one resident doctor had a phone call to member of rush team, and almost 80 PGs and some doctors gathered, and relative were absconded. So in this type of situation, to show solidarity and unity is very much important. So role of rush team in this type of situation, because balanced teamwork is always beneficial, not only to the patient and relative, but to our medical fraternity also. Communication with relative, how to declare bad news is also very much important, because these are certain potential conditions to provoke violence. So never immediately declare any patient dead when brought in casualty or died during treatment. So previously, this type of advice were given. Once patient died in your hospital, would you like to declare there only, or would you like to shift patient to nearby ICU and to make a show that you have tried your level best? But in nowadays, it is very easy to prove exactly when patient was expired. So remember, it is easier to fight a case of negligence rather than case of forgery. So declare death at your level only if at all it happens in your hospital. As far as involvement of police is concerned, so call them if problem is suspected and involve them since beginning. Many times it is very much important. So inform police and keep record of informing police. So whenever you inform police, it should be informed with acknowledgement. Action to be taken when violence occurs. If you know some miscreants with name, then file complaints against those miscreants with name. And if you do not know by name, then some unknown person, but file a complaint in police station in this type of situation. One more tip, very important, photograph. Photographs of damage occurred in your hospital or injured staff or yourself. So this is very important document to face in court of law when we file a complaint against miscreants. So this is very important, and again this will require for insurance purpose also, and we will have to submit all these photographs to police as far as further investigations are concerned. Medical checkup of injured. This is also very much important. Doctor or hospital staff are injured, they should be sent to nearby government hospital to have a checkup and all the treatment, and this all should be documented, because this becomes a good defense when you are facing case in court of law. So medical checkup of injured is very much important. Involvement of politicians, this is double-edged sword. Many times they could be helpful in this type of situation, but they may take undue advantage in future also, but you may take decision accordingly as per the situation. Because many a time this was asked that do not involve politicians, but it depends upon the condition by condition. As far as laws are concerned, does violence against doctor need a special law to deal with, or IPC and CRPCs are sufficient? So these are some provisions in Indian Penal Code, culpable homicide section 299, to kidnapping, abduction 359 and 374. There are enough provisions in IPC, and one more medical ordinance which is prevalent in few of the states. In this type of situation, service person and Medicare service institution, prevention of violence and damage or loss to the property ordinance 2009 is concerned. And in this ordinance, say for example in Andhra Pradesh, Maharashtra, Rajasthan, Gujarat and few of the states, in this ordinance, provisions are provided. It is cognizable, non-bailable and triable by first class magistrate court only, and provision of imprisonment not which may extend up to 3 years, and fine of rupees 50,000, and compensation that double the amount of loss in the hospital. And many times court may prefer to go for 3 times the damage. So this is some good ordinance in few of the state of our India. Copy of the act. So this type of provisions in IPC, CRPC and in this type of ordinance, so we should have a copy, because many times police also doesn't know how to deal with in this type of situation. As far as insurance company is concerned, if you are covered with insurance company, inform insurance company with all the photographs of damage occurred in your hospital. As far as compromise is concerned, many times what happens, after a few times, party will come to you and have a compromise when you have filed a complaint against miscreant. Never compromise, and many times you cannot compromise, because it is a non-compoundable, and once you file complaints against anybody, state becomes the complainant. You are no longer a complainant, you cannot withdraw the complaint. So in this type of situation what happens? And last that we done. So we started with that story of 27 years old boy which happened in city of Pune only. So in that particular case, it happened with our own gynecologist, and now father of that boy, who was boy at that time when this incident happened, now he is engineering graduate, and now he wants to go abroad for further study. But under this complaint, his passport is under custody of police, and so now his father is asking to doctor to withdraw the complaint. But doctor is very firm not to go for withdrawal, because he has decided to go with a message to be learned by that miscreant. So it is very important. One more tip under electronic surveillance. So CCTV, etc. footage are very much important document in our favor when we have to face this type of problems in court of law. As far as security is concerned, so you can have a security guard, but it has been experienced in this type of situation. First person to run away from the incident is security person. But can it be done? So if you, in few of the hospital, few of our friends have started this practice also, and this is real things in city of Delhi. So they have hired this type of bouncer. They will simply stand, nothing. If at all doctor is at danger, then they will be at rescue of doctor. So should we consider this also, or can we manage like this? This is also real happened case in Gujarat only. I have 2 minutes now. See how he could manage the situation. Young doctor. He is pediatrician from Bharuch in Gujarat. That relative of patient with chura, long knife, see. So all was captured in CCTV footage. So how he could manage, see. So can everybody do like this? Of course it is difficult one. Or should we consider to apply for license for forearm? And as far as documentation is concerned, it is very important. So we should have all the records in our hospital as far as this type of incidents happen, because doctor is bound to produce record whenever asked by the court, and good record is good defense, poor record is poor defense, and no record is no defense. Only 1 minute. So we doctors are very poor as far as record keeping is concerned. This is my experience during my medical legal practice. Foreseeability and anticipation is very much important. So you should anticipate certain conditions. So this type of problem may happen, and you should be readily available to deal with the situation. So to conclude, be vigilant in your practice. Security alerts, rush team, CCTV at every strategic point, copy of the act, documentation, communication about mishap needs special attention, and expert opinion whenever you are in need, proper communication with relatives, inform police in time. This gentleman have so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So there are so many provisions in law in our favor, but many times we do not know. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. Formation of local level medical legal cell or rush team is very much important and need of day time. And this is picture of city of Nanded only, how rush team or our unity can come to the result. So in one of the cases in Nanded, it was happened, and crowd of more than 100 doctors were there to protest this, and they had a agitation, and ultimately dharna pradarsan, etc. And ultimately authority had to come into picture to take stringent action against the miscreants. अच्छा है कि नाव में छेद हमारी तरफ नहीं है, but we are never, we should not forget that we are sailing in the same boat, and योग करे या ना करे, लेकिन एक दूसरों का सहयोग जरूर करें. So identify yourself well in the court whenever you are facing this type of problem, and remain alert every time. Otherwise, be ready to face this type of situation in this type of situation. Because in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. And this is real strength. Medicine is science of uncertainty and art of probability. And problem with world is that intelligent people are full of doubts, while the stupid ones are full of confidence. And only two things are infinite, the universe and human stupidity. And I am not so sure about the former. So wish you and me too all the best. God bless you, and have a litigation and violence free medical practice. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. There is always a way. Sorry. So this is law of leopard behind innocent gynecologist, and how medical legal counselor can be helpful in any given situation. So please do not hesitate to take role of medical legal counselor in any given situation. We are always there to assist you. Thank you. All the best. With regards, salute to the Kanchipuram Ubijayan Society. Thank you. Thank you very much. Please do not assume. Please ask if time and chairpersons permit. Thank you. Thank you very much.
Thank you so much, sir. There's a need of the hour, and you have done it so well. Be alert, and we do not panic, and you gave us really 10 commandments. I think with that, we will have a free litigation service to continue. Thank you so much.
Thank you. Thank you.
Thank you, sir. Thank you for your elaborate presentation. It was very useful for us. I request Chakravarti, sir, to felicitate and honor our chairpersons. I request sir to hand over memento to Fatima ma'am. I request
I would like to invite Dr. Saraswati Madam for chairing the session. Dr. Shivan Kumar sir. He's a consultant of Andhra Pradesh, former Professor HOD Chengalpet Medical College, former Professor HOD Melmaruthur Medical College, Professor and HOD in Satyasai. Sir doesn't need any introduction. And I would like to invite Dr. Shobana for the capsule.
First of all, let us thank the organizers, Dr. Chakravarti, Dr. Umayal, and Kirtiya Devi for giving us the opportunity to chair this session. First, I invite the speaker, Dr. Shobana. She is postgraduate from Kilpak Medical College. She is talking about PI, NIPT, I want to tell about this because we had recently a case, doctor couple reporting at 5th month for anomaly scan. It was found, they have done all the investigations previously and they found everything was normal, but when the anomaly scan was done, there were a lot of anomalies in the baby and they have been advised to terminate the pregnancy. So let us hear from the speaker whether NIPT can help in avoiding this type of catastrophes. The floor is yours, Dr. Shobana.
Thank you, sir. Good afternoon, everyone. Myself, Dr. Shobana from Government Kilpak Medical College. I am here to present about NIPT. That is nothing but non-invasive prenatal testing. It's used to screen chromosomal aneuploidies. So before going into the proper topic, what's chromosomal aneuploidies? So the most common chromosomal aneuploidies we are dealing is Down syndrome, which affects 1 in 700 live births.
Excuse me, I welcome Dr. Saraswati Madam for chairing the session. She has done her MBBS in Tanjavur Medical College, DGU in RSRM, MD in IOG. She had a membership in professional bodies, OXY, FOXY, NAF, SFWI, ISOPAP, and she is a selection committee member in JIPMET 2009 to 13, President, Jain Sali International, MET Curriculum Committee member, President, OXY 2006. Over to you, ma'am.
Can I continue, ma'am? Yes. So before going into the proper topic, what's chromosomal aneuploidies we are dealing day-to-day life? Down syndrome is the most common aneuploidy which affects 1 in 700 live births. So the options available for aneuploidy screening were, conventionally we are using first trimester NT scan along with the biochemical methods like PAP-A and beta-HCG. In second trimester, we are having triple test and quadruple test. Triple test which includes beta-HCG, alpha-fetoprotein and estriol. Along with if you are doing inhibin A, it's quadruple test. Recent advances, we have NIPT. It is not recent actually, NIPT have celebrated its 11th birthday. Yes, you have heard correctly. It has started from 2011. In y-axis, you can see the detection percentage rate. Since 1960, it has evolved from 2011. Now we are using NIPT with the detection rate of 99.1%. So NIPT is nothing but a non-invasive prenatal test which is performed on a maternal blood to detect the cell-free DNA of the fetus to screen for most common chromosomal anomalies. So what is this cell-free DNA? Which is nothing but a rapidly dividing syncytial trophoblast from the placenta. It constitutes about 3 to 13% of the total cell-free DNA of the maternal blood. It's detectable from as early as 5 to 7 weeks of gestation, but ideally we are suggesting to do NIPT after 10 weeks. I'll tell in later slide why we are suggesting after 10 weeks. And rapidly it is cleared by the renal system mostly and undetectable 48 hours post-delivery. So you can see the trophoblastic cells which is undergoing apoptosis and reaches the maternal blood. From the maternal blood we are doing cell-free DNA. So to whom we are suggesting non-invasive prenatal testing. Advanced maternal age, 35 or above, screen positive for combined test, and the patients who are very anxious for invasive procedures, to whom we are not suggesting NIPT. Fetal anomalies on the ultrasound. If you are seeing fetal anomalies on the ultrasound, we'll go for any invasive procedure. And vanishing twin, why we are not doing NIPT in a vanishing twin? Because the trophoblastic remnants of the vanished twin, which is blue in color, will be present in utero. It will give false positive in our NIPT. And we are not doing in multiple pregnancy because we don't know which fetus, if it is coming as positive, we don't know which fetus is having aneuploidy. And the genetic syndromes which cannot be diagnosed by NIPT. So why we are more concerned about NIPT now? We are having so many tests. Now why we are going into NIPT? It has more increased detection rate. We already said 99.1%, and it has reduced false positivity. Of course, it has false positive if the patient is having placental mosaicism, and it has reduced number of invasive procedures, obviously reduced risk to the fetus, and it can be offered to all the women. So you can see it has more than 98% of sensitivity when compared to other routine tests we are doing, and more specificity, more than 99%. In India, we are doing only for Down syndrome. Coming to the factor, fetal fraction. Fetal fraction is nothing but the amount of fetal cell-free DNA divided by the maternal DNA in the what we draw blood from the maternal into 100, which gives the fetal fraction. So why we are more concerned about fetal fraction? If it is less than 4, we have to go for no call result. We have to we don't go for the test. We'll go for no call test if it is less than 4. We'll go for genetic counseling, diagnostic ultrasonography, and invasive procedure for karyotyping. So the ideal amount of fetal fraction in a given test to achieve the best performance is 8 or above. So this is an example from USA or Hong Kong. We are not, this is not from India because we are not doing fetal gender determination. You can see the fetal fraction, 7.1. It's somewhat equal to 8. So we can accept this as good NIPT performance. So what are the methodologies available for NIPT? Counting method and single nucleotide polymorphism. Counting method is nothing but we have to take a 9 to 10 ml of blood sample from the patient. We have to process maternal and cell-free DNA from them. We have to undergo massive parallel sequencing, which will result in millions and millions of fragments. We have to just compare with the reference chromosome what we are having in our computers. It will give a result of excess or deficit of target chromosome. Single nucleotide polymorphism is nothing but we all will have separate identical genotypes. Even from our parents, we will not carry same genotype. So from the maternal blood, there will be buffy coat which will have only maternal DNA. And we'll have the base coat which has both maternal and fetal DNA. From then, we can derive fetal genotype. We already can derive from the maternal blood what could be the fetal predicted genotype. We can compare both the predicted genotype from the computer and what we got from the fetus inside, and we can get the abnormal single nucleotide polymorphism detected. So, what are the scopes of NIPT worldwide? In India, we are just concerning NIPT only for Down syndrome. We are not doing anything other than Down syndrome screening. But in USA and Hong Kong, in everywhere worldwide, we are just using fetal gender determination, which can be based on the presence or absence of Y chromosome. And we can detect fetal RH isoimmunization. We can diagnose single gene disorders, autosomal dominant, autosomal recessive, cystic fibrosis, etc. We can use as a diagnostic marker of preeclampsia by seeing the elevated cell-free DNA, which is seen in the abnormal placentation. Even incidentally, maternal cancers can be first diagnosed during NIPT. So last two slides which concern about our clinical practice. ACOG recent guidelines 2021 upgraded NIPT is, even though it has more sensitivity and specificity, we are not using as a diagnostic testing. It should be offered to all women regardless of age and risk of aneuploidy. It should be informed that the test failure will go for no call test. We already discussed in previous slide. And all patients should be offered with second trimester anomaly scan. Even though the NIPT comes negative, they should undergo anomaly scan. In India, we are just using for high-risk population. NIPT does not replace diagnostic accuracy and precision of invasive testing. Low cost. At the starting of 2013 May, India had our NIPT first test. It costed 28,800. Now it came to 8,000. Abnormal test report needs confirmation by invasive testing. Thank you. We can just compare NIPT simply to pap smear. We are doing pap smear only to screen the patients. It is not a diagnostic test. If we are seeing a visible lesion, we are not going for pap smear. Similarly, for NIPT, if we are seeing anomalies in the ultrasound, we are not going for NIPT. We have to go for diagnostic if it comes positive. Thank you for this opportunity. Thank you.
Thank you very much for your elaborate presentation of NIPT. Any questions? We'll reserve the questions in the later
End session. Okay, sir. Thank you, sir. Thank you, ma'am.
Good morning, everybody. Please excuse me for the late thing. Yeah. So the next topic will be on by Dr. Chinmayi, MSOBGYN, MRCOG and FIMSA FIDOG. Now the present appointment of hers is Director and Leading Consultant, Fetal Medicine Resolution Fetal Medicine Center in Hyderabad. Fetal Medicine Foundation UK approved trainer in India, an RCOG moderator for ERP, MRCOG, and so many credits are there. I'm not going to talk about everything. Maybe I can talk about the posts presently held by her. She is the Treasurer OGSH 1921.
It's okay, ma'am. Shall we
Member Representative, no, this is important. Member Representative AICC RCOG 2122. And Chairperson-elect Foxy Perinatology Committee 2123. And her topic will be on treatable congenital anomalies.
Thank you very much, ma'am. At the outset, thank you very much to the Kanchipuram Society, Umayal Madam and Chakravarti sir for this opportunity to stand here. And I have luminaries in the audience with two past presidents here. A very good morning to all of you. So treatable fetal anomalies is something which, you know, we don't actually expect in every pregnancy, because every pregnancy starts with a dream of having a happy and healthy baby. In fact, the whole purpose of pregnancy is to have a happy and healthy baby. But then we know that about 3 to 4% of all pregnancies can be affected by a congenital anomaly. Just like sir said, sometimes whenever you do ultrasound, you find anomalies. Anomalies may be malformations, deformations, a part of agenesis, or some kind of dysfunction. But once there is a diagnosis of an anomaly, then you start a long journey. The journey has to determine whether this anomaly can be corrected or not corrected. Some anomalies are really, really bad and they do not allow a good quality of life, or they can be completely lethal in themselves. So that is not compatible with life. That can lead to termination of the pregnancy. But some anomalies are treatable. So once you find something which is treatable, you then think what to do next. So what is required is complete workup, genetic counseling, and planning further care in those anomalies. There you realize that the answer to the crisis in the pregnancy is to eliminate the crisis, not the pregnancy itself. So now the journey of any treatable anomaly begins with the aim of achieving a good perinatal outcome. So this is a 26-year-old primigravida. For the first time she went for an anomaly scan and a unilateral clubfoot was found with no other abnormality. All of us sitting in the audience will think, oh, just one unilateral clubfoot. But you know, for the parent, it comes as a shock. They didn't expect anything wrong with that thing, and suddenly you are telling her something is wrong with the foot. And they would not have the background knowledge to imagine what is wrong. So for all practical purposes, they are thinking of a child in a wheelchair, or they are thinking of a child without a complete leg. You know, they don't understand. So first and foremost, it's very important to analyze, understand, and explain the problem. Just now MC Patel sir said, we have to counsel, we have to talk more. So we have to communicate to the parents what exactly is the problem. And of course, if you want to analyze any problem with limbs, you need to know what is the screening history, what is the spine, movements. The scientific aspects of that anomaly have to be really dealt with by the fetal medicine doctors, and at the end of it, they have to be explained. If necessary, involve the neonatologist and the pediatric neurologist if you think that any of the spine or anything else is involved. If nothing, then just show them pictures of how clubfoot can be treated after birth. Give them data of what happens in your own center, how other people with clubfoot have been treated, and that makes them little more, you know, positively motivated to continue a pregnancy with a treatable anomaly. This is a problem where there is an anterior abdominal wall herniation. This is an ultrasound scan picture which is showing that the bowel is herniating from the level of the umbilicus. This is known as exomphalos. Again, you can diagnose it very early, but again, it is treatable with some conditions. It's a condition which can lead to certain modifications in the continuation of pregnancy because it's associated with polyhydramnios, preterm birth. So the obstetrician has to plan some things. If the parents want to continue that pregnancy, you need to have a complete workup, you need to have a clear plan, and you need to team up with other people. And those team members will be your neonatologist and the pediatric surgeon. So if you can team up with all of them, talk to the patients properly, give them a clear plan of action, then you can have a good outcome. Like in this case, it was a term delivery and the baby was operated after birth and the outcome was overall good. So antenatal counseling is important for a primary awareness of the condition. What inputs do postnatal surgery require? Surgery may be available, but if the parents are not in the place where the surgery happens, how will they transport a sick neonate to another place? If they are not ready with the finances, suddenly they can't make arrangements. So antenatal awareness helps in all that happening. Local data give them confidence. If you say that we've operated so many exomphalos last year and that's been fine, that helps. And continuity of care is maintained. But the same exomphalos may not behave this way if there is an associated chromosomal abnormality. Some exomphalos may be associated with trisomy 18 or 13, and if that is the case, then the outcome is not going to be good. So at the very beginning, your complete workup, your genetic associations have to be ruled out, and then a proper plan of treatment has to be made. Another very treatable anomaly is cleft lip and palate. From the doctor's point of view, simple cleft lip and palate. From the patient's point of view, a very horrifying experience because when the child will be born, it will have a great degree of disfigurement. Apart from disfigurement, feeding is going to be an issue because even sucking would be a problem for that neonate. So what is important is you again analyze, look for all associations, tell the patients that there is good outcome. And this, in our state, we have a government supported program called the Smile Train, and it's run in the government institute. The plastic surgery department of Nizam Institute of Medical Sciences allows these patients to come in antenatally. They show them pictures, give them information leaflets, they show them videos of people who've had these correction. And really our continuation rate of cleft lip palate has improved in the last 5 years because consistently patients have been doing this, and it's also a free of cost service. So that adds to the compliance. Although not 100%, almost 90% of our cleft lip palate people continue. Hydronephrosis, whether it is single, whether it is bilateral, what is the extent of renal damage that is expected. So all this needs to be worked out in a systemic manner. Talk to the pediatric surgeon, talk to the pediatric urologist, and then, explain to the patient how good or bad the outcome is going to be. So all you need in treatable anomalies is a multidisciplinary team, constant communication, and understanding of the primary pathology. For example, these were limbs and cleft lip palate. Suppose there's a lung lesion. Either there's a mass in the lung or there's diaphragmatic hernia. Now, diaphragmatic hernia has to be quantified in a way to prognosticate it by using certain ratios like the lung head ratio. So the person who's evaluating a diaphragmatic hernia in utero should be giving this kind of information to the obstetrician and the pediatric surgeon so that he knows what the postnatal management will entail. Postnatal surgery is very much possible in diaphragmatic hernia, but the results depend on how good the lungs are after the surgery, how good they will expand after surgery. So if you describe a diaphragmatic hernia, just mentioning a diaphragmatic hernia does not help. Give the details, left or right, what is the lung head ratio, what are the other features that you are seeing, are other contents of the abdomen in the thorax like kidneys, spleen, other things like that. Then the surgeon will get an idea that what was my observed LHR, what is the expected LHR, am I going to get a good result from this surgery? If it's not going to be good, then perhaps they can decide to terminate because it is treatable but with conditions. So sometimes when it is treatable and you work it out correctly, this requires what is called an exit procedure, ex utero intrapartum treatment. You deliver the baby, immediately put the baby on ventilator and make arrangements for that surgery, optimize perinatal circumstances and give a good outcome. Sometimes in utero treatment is possible. Unfortunately in India we still don't have it, but for diaphragmatic hernia which otherwise has a poor prognosis, you can do it in utero occlusion of the fetal trachea. So through fetoscopy, you can go in, put a balloon in the trachea and occlude the trachea so that the lung volume is maintained. And even if the diaphragmatic hernia is actually severe, it will maintain some degree of lung volume, deliver the baby at full term, and then do postnatal surgery. The outcomes will be good. This is a trial going on in the Europe, the total trial. But the results are kind of good with some degree of, again, conditions apply. But right now we don't have this facility, so in the absence of that, exit procedures are our only option. Similarly, you can have other cystic malformations in the lung, and sometimes there are these big cysts which can compromise the lung volume and even lead to high drops. So these are indications of doing in utero therapy where we go in and decompress that cyst in the fetal lung. So this was one of our patients who had a very large macrocystic CPAM, and we did a intrauterine shunting. She delivered the baby at term, so she had a live baby, although the whole pathology doesn't go. That shunting is only a palliative procedure. And she was counseled, she knew about it. So after almost 1.5 years, the child had the surgery and removal of that, malformed area was done in the lung, but the child is having a good life now. So any anomaly which is treatable needs to be worked up from the beginning. Parents have to know the clear plan of action and they should be ready for the follow-up. This was a case of a clover leaf skull. This child was referred at 31 weeks and the head looked definitely malformed. Now what we did was we worked up that, we saw which sutures were absent. This is a kind of craniosynostosis where this happens, and met with the neurosurgeon. The neurosurgeon looked at the brain inside, said everything is looking good, no antenatal treatment required, let the baby deliver, then I will treat. So this child was delivered, and if you see there is gross dysmorphism in the face. But we know internally the brain is normal, it's only the skull which is abnormal. So instead of panicking at that point, she came for a postnatal surgery, and if you can see that sagittal suture is completely fused, and that is not how it should be at that age. So what they did was they did a fronto-orbital reconstruction with a biparietal release, and the baby had a good skull shape thereafter. She's doing very well. I mean, this has been followed up. This is a case of a rudimentary extra limb in the baby, diagnosed very early at 18 weeks, but the patient continued. And you see the baby was born with that extremely big mass in the back. This is after full consent and awareness. And therefore they went on day 15 surgery was done. And the pediatric surgeon beautifully cleaved out that extra limb, and the baby is doing very well. What was required? That we had to have a thorough antenatal workup, that there is no connection with the neural canal. If it would have been, then the outcome would not have been great. But there wasn't a connection, they continued, and this worked out. So a good antenatal workup always helps. This is a G6A5 presented with a rare cardiac anomaly called total anomalous pulmonary venous connection. You know that the pulmonary veins are not draining in the right place. When that happens, there will be a problem after the birth of the baby. Cardiac problems don't lead to issues inside because already the placenta is giving you oxygen. But once the baby is dependent on its own heart and lungs for oxygen, the prognosis becomes bad. But if you are aware of this, you know that these problems present with a very subtle change in hypoxia status. So because you are aware, you look for that, and then postnatally you plan for an repair. The baby has specialized NICU care and undergoes that repair, and things do well. For a G6A5, it made a lot of sense to continue a baby and have that surgery and still, have a good outcome. So all types of cardiac diseases need not be terminated. They are classified into different types based on their primary pathology, whether there is, more blood passing through the lungs, less blood passing through the lungs, or less blood passing through the body. And there is a set of cardiac problems which have very good outcome. So again, what you need to know is what level of care this particular cardiac condition will require. For that, the American Heart Institute has given clear guidelines. In certain problems like mild tetralogy of Fallot or some shunt lesions, you don't even need to send to a very tertiary level NICU. You can deliver them in your own setup and shift them to NICU later on. Whereas if something like a DTG or sustained tachyarrhythmias, you have to have a very tertiary level NICU. So that workup, if it is done, and your patient knows where he'll deliver and how the postnatal care will be done, the outcomes are going to be good, and even medico-legally you will be safe because they will know exactly what is entailed in the postnatal period. Nothing will come as a shock at that time. So it's important to know whether the problem is correctable. Is the surgery available at our center? Is it feasible? Can we go to another place and do that? What are the financial requirements, time requirements, and what is the expected follow-up in the long term? So optimizing multidisciplinary perinatal care in correctable fetal anomalies is something we have to start being aware of, because as you saw, there is advanced maternal age, there is a lot of other environmental teratogens happening around us, and therefore we need to be prepared to address the issue of managing these fetal anomalies. It's not a one-man job, it's a multidisciplinary job, and it's an ongoing thing. You've counseled the patient at 18 weeks, but things might change at 28 weeks. There might be something else happening to that pregnancy. So you must be ready to constantly be with your patient and give them solutions on an ongoing basis. So what we visualize in fetal medicine is to help couples with diagnosed fetal anomalies to optimize further care, devise a multidisciplinary care team, and obtain health insurance for the sick fetuses. That is one thing we are still lacking. I have seniors here and I would request them to take on this mission, because we do not have health insurance for sick fetuses. We have for sick infants, but not for congenital anomalies. If the government allocates more funds to this fetal health status, because somewhere where cardiac surgeries or cleft lip palate surgeries are free, people are happy to continue and take care of them. So for any treatable fetal anomaly, it's important to prognosticate, plan antenatal care, plan delivery in the correct circumstances, and neonatal care and follow-up. So always the patient will ask, can you give us a guarantee, doctor? So you cannot guarantee that you will cure everything, but you can always guarantee that you will care for everything. Before I finish, one quick recap of a case. Every time outcomes are not good. Whatever I presented, a lot of success stories. But this was a patient who was an engineer herself. CDH, diaphragmatic hernia, was diagnosed at 18 weeks, and she decided to continue the pregnancy. And she took all our advice. The whole A team was after her. There was no financial crunch, nothing at all. And she went on and delivered at 38 weeks, a healthy, average for gestation baby boy of 2.75 kg. But we could not do a surgery because whatever we did, the lungs were not expanding, and the surgeon said, there is no use for me to do this surgery. We should just give up care on this baby. So after 48 hours, the baby died in the NICU. And this was a patient who was following us from 18 weeks, and she had done everything that we had advised. There was nothing that she had declined. And finally, the baby had died. So I asked her, do you regret the decision? Should we have not continued? Because it was a primi gravida. She ended up having a cesarean section, and finally no baby. This is a letter she wrote to me after many days, because at that time she was very let down, but later on she wrote this letter. She said, I have no regrets. My baby did not end up being a medical waste product of termination, but saw the light of this world. Because of that, I am a mother today, not just a woman. The fetus, which was told to be terminated by everyone, came into this world as a baby boy and has a name, Pradyumna. Today I have a new identity. My name is something, and I am the proud mother of Pradyumna. So that is her feeling as a mother for something that she did for a baby whom she would have otherwise terminated if we had not given her hope. So whether the outcome is going to be good or bad, we do not know. So we repeat this every time to our patients, that we definitely cannot cure everything, but we definitely can care for you. And with that spirit, if we approach congenital anomalies, then you know the panic is going to be less from the doctor's side, from the patient's side, and we will learn to accept what nature has made it inevitable. This is a process, and the process can go wrong anytime. So there is an inherent 3 to 4% risk of congenital anomalies. Just because we detect it, we don't have to become defensive the moment we detect it. So please understand that with a routine anomaly scan, we will be detecting these anomalies. And after knowing that it is treatable, there is a path ahead. Where it leads to is a bit of destiny from both the patient's side and our side, but we can definitely try to give a good perinatal outcome. Thank you for a patient here.
Thank you, Dr. Chinmayi, for your excellent presentation. Of course, fetal anomalies, as you rightly said, something, many of them are correctable. But only thing is, as you rightly said, it has to be identified early. And then after identifying, you have to classify, whether you have to discuss whether it can be treatable to a certain extent at least. If you think so, then as you rightly said, multiple disciplinary action should be taken. You have to consult your fetal medicine people and maybe even pediatric surgeon, so on and so forth. And more than anything, counseling for not only with the mother but also with the family.
Family.
Very, very important. Repeatedly, we have to counsel them. As you write, and I'm really very much moved by the last, the last case which you have discussed. And the mother was so happy. Okay, so hats off to you for the same.
Thank you so much, ma'am. Thank you.
Now let me call upon the next speaker.
Thank you very much, ma'am. I consider it a great honor to invite Dr. Hema Divakar, madam, very humble and senior person in the field of obstetrics and gynecology, to give a talk on technology transforming women's health care, a peep into the future.
Dr. Hema Divakar, she doesn't require any introduction. She is evergreen heroine of OG conferences. She has been attending almost all the conferences throughout India, even worldwide. She is, let me introduce her, Medical Director, Divakar Specialty Hospital, Senior Consultant Obstetrician and Gynecologist with over 3 decades. She doesn't look like that. Of experience and expertise in women's health care in India. And opinion leader and past president of FOXI 2013, vice chair for FIGO PNCD committee 2015 till date, Ambassador to the International Organization of OBGYNs, FIGO 2016-2018, Technical Advisory Group TAG, member of for Ministry of Health and Family Welfare, Government of India, an advocate for delivering quality healthcare and capacity building, an influencer for social and legal issues relating to women's health. Awards and recognition: FIGO Women's Achievers Award 2015, Global Asian of Year 2018, Excellence in Women's Healthcare, Ministry of Maternal Health, CME Excellence Award for Artist, Next Brands Award for Artists for HER, CSR Times Award and CSR Impact Award for Divakar Service Trust. Madam, the floor is yours. At the end, you have to tell what is your age. So that. Thank you very much. Floor is yours.
Vanakkam. Age is just a number, Dr. Shiva. I think the more inspired, innovative, and generating ideas that you have, you will constantly remain in the spirit of giving and the joy of giving. I must, first of all, place on records to the respectful chairpersons, Dr. Siva and Dr. Saraswati, who 2 decades ago in her esteemed institution helped us to do the labor analgesia workshop, and a very affectionate president of the newly born Kanchipuram Society, Dr. Chakravarti sir, the dynamic Umayal, and the vibrant team Aval. I was just asking Charmila, somehow Aval did not strike to me as her, because I thought Aval is like Avial, you know. Aval in Kannada we say Avalaki. Again, you know, it's everything to do with eating. And why is this, you know, Aval, it looks like little, but Aval. And I also asked Umayal, what are those arrows pointing at? Then I decided to conclude for myself that reaching every girl, every woman, that's where those, you know, arrows are leading. And 2 more words, Umayal: ideate, innovate, inspire, implement, and impact. Those 2 are the very, very crucial steps and the gap. And my very beloved Chinmayi just told about so many situations. She presented that letter in the end, which Umayal appreciated. What Chinmayi did not read in that letter, which I saw, was, Doctor, you have helped me through tough times. I know you're just paid for your job, but there is so much more that you have done for me. Beyond that is the humble Chinmayi who did not read those lines of appreciation which are mentioned. So reading in between the lines and reading the small print is what the maturity over the years has taught us. So congratulations again. As we speak again about this fetal medicine, which is very, very tough kind of a call that we as doctors and the couple and the team has to take. As how we were discussing in one of our online conferences, we came up with the idea, this is the era of Zoom. How do you reach every couple to actually counsel them in the manner that they should be? So we hit upon the idea that whenever we come across these cases, it's best to reach out to people like her. So we've already initiated that process with Bijoy Balakrishnan, where we set up a Zoom meeting with a couple, with our sonologists, with Bijoy, and us. It is still slowly picking up. We have about 1 such couple per week, and we are slowly building over that, the system, how we can reach many more couples. And the message for all of you is, don't give up. There is a way, if you have the will, And COVID has taught us a lot. And that is why a peep into the future, as I call it, reaching every girl, every woman. Everybody, just about everybody has a role to play. We have to change our attitude and say, direct face-to-face, touch and feel, look. And of course, we are delighted to be here in Chennai for a face-to-face meeting. But there are many constraints for many more people who could have come. So we have to constantly work in a hybrid manner in our own minds and say, hey, when you cannot reach the last mile, maybe the technology will help you get there, and why not? Of course, in metro cities, when affordable patients, if you ask them to come once a month, they may be ready to come 10 times a month. That's a separate scenario. But the constraint for access, when it is there, the inventions and innovations which are revolutionizing the women's healthcare. Even the WHO has recently come out with a guideline that 10 visits, out of which 4 visits are compulsory, but many other visits can be a touch point visit. Somehow you connect with the patient and get the information. She need not always physically come there. Either Asha worker goes to her doorstep or she connects with you on a video call. But connect is there, information is there, but the cost and the efforts and the doability is quite great. Then the only thing we should thank COVID is for changing everybody's mindset. Metro, non-metro, rural, semi-urban, the last mile as we call it, everybody had to compulsorily get on with whatever best that was available to them. So this is one example of a number of high-risk patients. You know how our high-risk patients are. They may have hyperglycemia, hypertension, but they are hyper, in short, because they, on one hand, want to see you for very many reasons, but they're also scared to come they were also scared to come during the COVID era, and they wanted to minimize the number of visits. So a number of patients with GDM, PIH, and IVF patients, one thing we asked them to keep a track is on the fetal movements. Sometimes they're so psyched up that they feel that nothing is happening, they're moving less, or we need to see them once a week, but we chose to call them once in 3 weeks. So how do you manage that? And what we would have normally done is at least to take a CTG to get the activity pattern. So this was one of our huge challenges. Right at that time, we recognized that what we were using in our setup, the regular CTG machine, compared to that, a wireless real-time remote monitoring. In fact, I call it like when I was explaining to the paramedical staff in Manyata, because we are introducing this small little machine into many centers in rural India. So I told them, have you eaten idlis? Yes, ma'am. Mini idlis. Do you know what is a mini idli? So now this fetosense is like a mini idli. It's small. It's as tiny as this. And there, everybody has a smartphone. They have to just download the app. And we teach them, it takes us less than 3 to 5 minutes to teach how they have to use it. It is wireless. They can keep it anywhere on their abdomen and record the graph which can be sent by the WhatsApp. So they have to download this mother care app, apply the gel on the baby beat, place it on their tummy. They can also listen to their heartbeat, and it starts taking the tracing automatically, and the reports are shared with us. This, when we wanted to do the digital skill transfer to some of the small rural nursing homes, which didn't even have a CTG machine, I said, let's try it out. And I had marked about 1.5 hours to ask them to keep a patient ready in their setup live, and had already sent the machine. And then we were doing through the Zoom platform, this is how it is, this is how to download, this is to keep out. But believe me, in that 1.5 hours, it just took 15 minutes to completely skill transfer, empower them to do. And right, left, and center, they're keeping on doing this, and some small technical hitch one day in one tiny setup, and they kept on 50 times they rang up, ma'am, there's some problem, it's not working. I said, hey, come on, till now you were not even having anything to do, and now that you got so addicted to it, even half a day it's not working, and then you kind of miss this small device. So this came in very, very handy. Now a little more enhanced new introduction, which the FetoSense is from IIT Mumbai. What they have brought in is, even a semi-skilled staff who doesn't know much about this should be able to kind of interpret. So you see, whenever there are accelerations, there are green putties. And when there's a deceleration, there is red. So if she sees a lot of green, then she knows that, everything is okay. If there's a lot of red, then she has to bring to the notice of the consultants immediately. So the 20 years back when we were doing the test for diabetes in pregnancy and discovered their hyperglycemics, to tell them to monitor at home was a challenge. Oh, glucometer, this, that. So we had bought 15 glucometers on rent, and whenever she was diagnosed, I used to give one glucometer on rent and till delivery, and then they used to give it back, because that time the concept of long-term care. Now, nobody needs it because every house has a glucometer. It's not the same way. Then we thought, based on that experience, let's buy a couple of more FetoSense machines. We had 2, but we bought another 8. And then all of these high-risk patients, we started renting it out to them. So alternate days, they send us the graphs, and they're very reassured. Even beyond the COVID times, when it is really necessary for us to monitor as many times, but it is difficult for them to actually physically come and spend so much time, and the clutter is also too much. So the machines are now constantly in use. But the usability, even the primies, 80% of them really, really could use it with ease. 76%, the reports were reactive, so they only needed reassurance. If we had a doubt, we said, come on into the hospital and then we will assess and do more. So as I said, now we have expanded this to about 12 more centers in Karnataka, but another 50 more centers have booked in. Next, we will be moving to Manyata centers in Tamil Nadu, because those are the staffs who are well in sync with us about the training and teaching methodology. So the COVID announcement brought everybody to rush for a digital device, and you see that necessity is the mother of invention. So the younger age group is already savvy with this, but even the rural women, everybody had to be in sync with this. You would see a picture with our hospital staff. We had initiated the Divakar's Hospital app about 8 years ago, because many of our patients who come from really far away, and you know how the Bangalore traffic is, just to show a report, just to ask a small query. And we said, no, you fix up a video consultation, and because it was not legally allowed to do a primary consultation. So when the shift happened during COVID, it was super quick for our team to engage into this video consultation. And I was also mentioning to you about how I could not understand what AVAL is. So Health for Her is a platform where we do the advocacy program in various languages. Some of our champions are right here. And the consultation also, we refer to the doctor where she can speak in her own language. So that is the kind of expansion now we are doing. So the remote consultation and health monitor, it's almost like, you know, the peep into the future is establishing a call center with robust supply of quality trained personnel who could filter the data. If it's a green zone, they need reassurance. If it's amber, they say you do this, that, and the other with the artificial intelligence. And if it's red, they say you should not wait, you have to seek care immediately. So 85% of the clinicians who were saying no, 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 started using the teleconsultations. 50 said that it was an effective tool. 80% were using it for the first time during COVID, and many, more than half of it was from non-metro cities. So the preconceptional kind of data that we used to get, fit to be mom. So, nowadays, many young girls, you ask them their menstrual history, they will open their mobile and start searching for the dates over there. So I would be lost without you, that they say. So it's very, very easy for us to get the data on very many things without a time lapse. When they are using this just about for everything, why is the health remaining the last of it to get on board? So when we take all of these histories, they have to say yes, no, or not applicable, or not known, and then automatically it analyzes, because there are so many of these things which you need to be anonymous: domestic violence, alcoholism, smoking, for example. And finally, it gives their risk exposure to tell whether they, again, the traffic signaling right at the end of the questionnaire that they have filled up. So, dear friends, we say that even in the field of diabetes, it's not the new insulin, but the digital technology which is going to be the future, because we oftentimes grumble that if the sugars go high, she need not come to the setup to tell us what the value is. We don't have to tell her, just increase 2 units of insulin in person when she waits in the long queue. Over there we can. And also we oftentimes tell that dietitians are lacking, diabetologists are not accessible. So everything can happen on the chat pail, especially some of the food advice that we can give. This also with another app called the Zuri app. We are expanding this big time. And very soon you will see the generation next with the wearable devices. We are in collaboration with an Israeli innovations authorities to get some of these through medical regulatory bodies into the countries. And the time is here and now to avoid the issues of access, affordability, and most importantly, the quality of care, which can be done in a standardized manner. So the vision, the PEEP, is both for pre-pregnancy, pregnancy, and post-delivery care. Couple of things which would be assessed at the point of care. There is also another screening test for thyroid. It's just like a 1 drop of urine you put, so the same way 1 drop of blood. It'll just tell you if the value is more than 3.5 or less than 3.5. So it's for mass screening. If it's more, then you can send them for the next set of tests. And the optimal weight, which we so very strongly emphasize that pre-pregnancy they should, and non-invasive hemoglobinometers. The pulse oximeter gave us an idea that the non-invasive hemoglobinometers, anywhere, everywhere you can do. Even our school health and hygiene programs, we have to take permission from the parents to do that single prick, which is not easy. So if it is OR Sense is the name of that non-invasive device, which is just getting into our fold of innovative devices that we are bringing in. So the kind of dashboards, the personalized intervention, the follow-up and the tracking and the outcome, all of these can easily be done. So with all these connected devices, really the patient has to come in only at the key points in time for a checkup. This is what we are hoping, preconception, antenatal, and postnatal. Beyond this, there are many more devices, including of a wireless ECG and 18 different tests, including the lipids and liver function tests that can be done at the point of care. And all this has been possible because there are more than 1,130 million subscribers for the mobile devices. So it looks as though it is easy to innovate and reach them by the digital device. But the ground reality is in India, you will know only when you experiment with this, because we are living in our own ivory towers, as I call it, because there is still gender and attitude behavior, traditional and custom, which are the barriers. Many people in the interiors of West Bengal, for example, the women are not given the mobile phones. We have to speak to the husband, and if we plead, then he may pass it on to her to tell her own symptoms, so on and so forth. So situation is very different, but it is changing. And even the capacity building We used to go travel the last mile ourselves, but we know that that is not enough. Here are the whole set of our staff saying, yes, we are ready to take on these newer devices, and the Meditech and the capacity building has scaled up in many, many centers. Today, Artist is working in 17 or 18 states as we speak, training in different languages. The frontline healthcare workers, as you would see, and Tamil Nadu is on the lead with 100% scores each time. And we are very proud of our connect with this state. So OPD care, NCD care, elderly care, women and child care, pre and postnatal care, and the home care for the geriatrics. Good health for all, well-being, reaching the last mile with digital health, health gadgets, mobile health, digital health devices. It requires many, many players. We are one of the cogs in this wheel. The IT support, the political will, which is already there. MC Patel and Alpesh are from, they're proud to be from the state of Gujarat, because there has been a phenomenal change with a Prime Minister being very, very keen on National Digital Health Mission, and all the data sets that we gather are going to go and get cut, paste, and sitting on the NDHM platform like the Aadhaar card. It's a dream to have each and every girl, women, and the community with their health card, which can be utilized anywhere by themselves in the entire country. And hopefully that the peep into the future, what we've taken, half of which has already become a reality. We do hope that if everybody has the mindset of moving forward, we will succeed in moving the needle several times faster than what we expect. Thank you very, very much. Namaskar.
Thank you so much, madam, for your elaborate and innovative talk. We are talking about cell phone not usage, but it has got a lot of value in health aspect also, for highlighting all this new technology. Any questions? We'll be talking in the interval.
Dr. Hema, once again, hats off to you. That was an excellent presentation. And definitely you said we are on the halfway through. Surely you will be coming when it is fulfilled completely. We are expecting the same. Thank you.
Thank you very much, ma'am. Next, I would like to invite Dr. Alpesh Gandhi, sir, to give a talk on importance of obstetrics high dependence unit in today's scenario. Over to you, sir.
I am really honored to introduce another evergreen hero of obstetrics and gynec society, Dr. Alpesh Gandhi. Many OGCians call him as father of digital OBGY in India, conferred honorary FRCOG by RCOG, main resource person for many national guidelines for GOI and for the country, pioneer for the concept of and establishment of obstetrics HDU and OICU in India, came out with first guidelines on COVID-19 in South Asian countries, many first time, many maximum and many initiatives, conducted many community connected programs on different preventable women's health issues to educate girls and women of India, worked a lot for curriculum, including publishing Foxy's first textbook for PGs, preparing LCDs and logbook for UG and PG, has been awarded as Dr. Abdul Kalam Living Legend Award, has been honored as one of the 7 legends across the world for cervical cancer prevention by IFCP, recently awarded oration of 45 minutes in FIGO's World Congress awarded oration. Okay.
Dr. Hema Divakar ma'am.
I am thankful to Chakravarti sir, Dr. Umiyal and Kanchipuram Society for inviting me. I am happy to see the growth and progress of Kanchipuram Society, which was started during my tenure in Foxy. So I am more happy to see the growth and progress in such a short span. So congratulations to all of you. I'm going to speak on a topic of importance of obstetric HDU ICU in modern practice, obstetric practice. It's a big topic of oration and I have hid nearly 80-90 slides, so please pardon me if I may take few minutes more. And at the beginning, briefly, I would like to mention about what is obstetric HDU ICU, what are the changes in recent obstetric practice, and why it is relevance to obstetric HDU ICU, what is the importance. What is quality obstetric healthcare? It's a use of sophisticated state-of-the-art equipment and technology, facility of invasive monitoring, facilities of life-saving interventions, facility of skill-based services, facilities of skilled and experienced persons, and facility of 24 hours monitoring. All this can be based accomplished only in a specialized dedicated obstetric ICU setup, but it may not be feasible or viable to start obstetric HDU or ICU in all the small setups and towns. So the concept of HDU came, where we can keep the high-risk patient, we can take care of high-risk pregnant women, and it is therefore known as high dependency care unit. Obstetric ICU is dedicated to manage only obstetric patient having critical medical or obstetrical or surgical complications, managed by staff oriented for obstetric physiology and pathology. Whereas obstetric HDU is an area in a hospital where high-risk patient can be cared more extensively than on a normal floor, but not to the point of intensive care. So it is in between facility in between the normal floor and ICU, where high-risk patient can be admitted. Most of them will be cured, care will be taken, but if they become critically ill, then can be shifted to ICU. So it is also known as intermediate care units or step-up units. Why it is important, why it is required? Initially there was a lot of debate when already there are MICU, SICU, then why OICU you want? So particularly when things go wrong in obstetric, they go wrong very fast. It's a area in the obstetric department. So whenever we require to shift the patient to obstetric OT or labor room, patient can be shifted easily and promptly, where it is not possible when she is an MICU. NICU is nearby, so neonate can be taken care. Fetal monitoring is not possible in MICU, SICU. Service of an experienced full-time obstetrician is always available in obstetric HDU ICU, and staff is, as I mentioned, acquainted with the obstetric pathology, physiology, and complications. Our patients are relatively healthy, and in MICU, SICU, acquired cross-infection rate is very high. In MICU, critical care is primary objective, making obstetric care secondary, whereas in obstetric ICU, and it ensures adequate provision of obstetric and critical care simultaneously. So this is why we need obstetric HDU and ICU for our pregnant mothers. And one more important reason is usually fully equipped laboratory and blood bank is a part of HDU, or it's a nearby facility, and lactation support is also available in obstetric HDU. Which are the recent changes occurred in our modern obstetric practice? I am not going to speak something new, But if at the end of my talk, if I can make you more sensitized about the use of, utility of obstetric HDU, then I would think my talk is, has impact or is. So which are the changes occurred in our country in obstetric practice? In India, hospital delivery rate was 27.6% in 1997 and 98, and maternal mortality rate was 398. And as per the MDG goal, we have to achieve it, MMR, we have to reduce it to 109 by 2015. For that, our priority was to bring more and more pregnant women to the hospital for safe delivery. So several schemes were introduced in our country, but the Jandi Suraksha Yojana, which was introduced in 2005, has brought revolutionary changes in obstetric practice. In 2005, hospital delivery rate was 35%, which has improved to 85% in 2015. And moreover, delivery conducted by trained person has reached to more than 90%. It means now more than 90, and in some of the states nearly 100% women are reaching to the hospital. And so now if they are dying not at home, not during transportation, but they are dying at the hospital. And so because of these changes, of course maternal mortality rate has improved a lot, but our responsibility increased a lot, because now we are responsible to save those mothers. So this is the biggest revolutionary change occurred in obstetric practice in India. As per unpublished survey in India, MMR in hospital delivery is somewhere between 70 to 90, which is 4 to 5 times more than MMR in developed world, which is between 10 to 20. And why? Because they need quality care. They need obstetric HDU. India is one of the countries having highest incidence of PPH, eclampsia, prematurity, IUGR, diabetes, septicemia across the world. But the sad part is case fatality rate is significantly high in India. Why? Again, they need quality obstetric care. They need obstetric HDU. Today, more and more often pregnancies become possible after treatment of gynecological, surgical, and fertility problems. And this has led to increase in incidence of high-risk pregnancy. Previously, the high-risk pregnancy incidence in our country was somewhere between 5 to 7%, which has increased to 15 to 20%. So the utility, so the importance of HDU increases a lot, because we need to take care of those 15 to 20% women, pregnant women, which cannot be taken care on routine floor or routine ward, and they require admission in obstetric HDU. Increased incidence of cesarean section, which was 3.2% in 1995 and 96, has increased to 28.1%, and in urban area it is 41.1%. And we all know that overall rate of complication is twice with cesarean section. Complications including PPH, deep vein thrombosis, pulmonary edema, embolism, stroke, organ dysfunction, future scar ectopic, rupture of the uterus, deep vein thrombosis. So many complications are more with cesarean section compared to vaginal delivery. So we need to take care of those women when they develop such complications. We need to admit them in HDU. Again, placental accretus syndrome disorder. Now, this is something new which was not previously so common. The risk of previa increases with increasing number of previous cesarean section, and combination of placenta previa or lower lying placenta with previous cesarean section dramatically increases the risk of placenta accreta. And the incidence of placenta accreta was 1 in 30,000 delivery in 1960 has increased to 1 in 500 deliveries in recent time. So routinely now we all are going to come across a patient of placenta accreta in our practice, and we all know that the how much serious condition this is. And even after post-op, we need to take close monitoring. We may need blood transfusion, massive blood transfusion. So many things are required, and for that we need HDU. Again, a study of British journal here, it shows this, that when patient is having accreta, 80% of the mother will have massive hemorrhage. And again here, this study shows that now, because of the placenta accreta, it is the second rank indication of obstetric hysterectomy. So, where to take care of such women with massive blood transfusion, with obstetric hysterectomy? We need HDU for them. Again, hypertensive disorder in pregnancy. HDP is a major maternal issue worldwide that is responsible for maternal, neonatal, severe morbidity and mortality. Lot of changes in management also. Now, edema is not considered as one of the diagnostic criteria. Nifedipine sublingual is not given. Now, screening for prediction is done at 11 to 13 weeks, 6-day scan. Now, biochemical tests are used along with uterine artery study. Now, early aspirin is suggested, and important part is incidence increase by 10.92%, and worldwide about 76,000 pregnant women die each year from preeclampsia and related complications, and 5 lakh babies die because of this disorder and complications of preeclampsia. So we need to take care of such women and such neonates, and that is why there is importance of obstetric HDU. Again, we know that when there is hypertension disorder, it can lead to HELLP syndrome, acute renal failure, congestive heart failure, ARDS, DIC, many complications, FGR, preterm labor, poor neonatal outcome, and now severe preeclampsia and its complication is #1 indication for admission of a pregnant woman in obstetric HDU and ICU. Again, worldwide incidence of preterm delivery increases a lot. And it is said that with one previous preterm delivery, it increased by 17.2%. And with previous 2 delivery, it increased by 20, possibility increased by 28.4%. And again, sad part is, India has the highest number of preterm birth across the world and highest number of neonatal death because of preterm in world. Now again, there is a lot of changes in the management. Now, in such cases where there is a history of previous preterm birth or abortions or congenital or uterine anomalies, we need to screen cervical length at every 2 weeks between 14 weeks to 24 or 26 weeks. Again, if usually 25 millimeter is a cutoff value per cervical length, but if we compare singleton pregnancy and multiple pregnancy, and then if it is less than 25 millimeter cervical length, then the possibility of preterm delivery increase by 4 to 5%. So we need close monitoring, we need close follow-up, frequent sonography, investigations of such patients. And again, management has changed. Now, tocolytics are not usually given for a longer time. All guidelines suggest the use of progesterone up to 32 weeks. Steroids are given when it is delivery is likely before 37 weeks. Injection Merxalp is given in preterm delivery to prevent neonatal neurological problems. Delayed cord clamp is recommended, and better NICU facility can save neonate with 800 gram weight. So a lot of differences are there in management of preterm birth. Again, 25% of maternal deaths across the world are due to PPH as per the WHO, and 14 million women globally suffer from PPH. PPH is #1 or 2 indication for obstetric HDU admission, and it is always nightmare for all of us. In one of the study conducted by WHO, it was found that 30% of the blood is used for obstetric purpose and not for trauma or not for surgical patients. So we should be very much careful for the proper practice of blood transfusion. And previously whole blood was used, and now the concept is the use of whole blood is an unscientific, inefficient, unhealthy and criminal waste of a valuable resource. And we now understand the importance of the components, and now components are used. We all know that when there is a massive blood loss, acute massive blood loss, patient may develop 4 types of problems: hypovolemia, hypoxia, clotting factor deficiency or platelet deficiency. But the solution for all these 4 problems are different. Hypovolemia require plasma expander, hypoxia require PEC cells, clotting factor require FFP cryoprecipitate, and platelet require platelet. And similarly, but it gives different optimum time for its correction. Platelet deficiency should be corrected as early as possible. Coagulation defects can be corrected within 2 to 4 hours. Hypovolemia required to be and hypoxia required to be corrected within 6 to 12 hours. So now management is changed. We have to manage patient as per the priority. If we are going to give whole blood, then the platelet deficiency will not be corrected since 6 to 8 hours or 12 hours. Then patient may require, the leak may not be sealed, and patient may require more and more units of blood, and there may be a scarcity of blood. Blood bank may not be able to provide those many number of blood units, and unnecessary patient may develop DIC. Many times DIC is not obstetric DIC, but it's a man-made DIC. So many complications are there, but now we understood all these things, and to take care of such women, we require HDU, because this is when patient is having massive blood loss and she is on massive transfusion. We require close monitoring, and it is not possible in routine floor. We require to admit her in HDU. In such patient, usually when there is a massive blood loss, we may require 4 to 6 units of blood. So ideally what we should do, we should take 2 IV lines with wide bore needle, and on one side we should give cryoprecipitate, platelet and FFP, and other side we should give red cells, and we should manage the patient as per the massive transfusion protocol. Basic principle is treat aggressively, treat to prevent refractory coagulopathy, and begins resuscitation with blood product as soon as possible, and it is usually managed in ratio of 1:1:1, and this should be guided by this laboratory assessment. Platelets should be above 50,000, fibrinogen should be kept above 150 milligram, HB should be about 9 gram. So all this cannot be, frequent blood investigations are required. So it is not possible to manage such patient on routine ward, and she requires admission in HDU. Again, lot of changes are there. Injection tranexamic acid is given. Now we know there are studies which suggest importance of role of prophylactic uterine artery ligation, role of prophylactic use of FFP. So many studies are there. These patients require admission in HDU. Again, DIC, as I have mentioned. Now we know that for DIC there is not a single laboratory test from which we can come to know this patient is having DIC. We may require a battery of laboratory tests. We may require serial investigations, and this is a score, DIC score declared by the International Society of Thrombosis and Hemostasis. And as per this score, there are 4 laboratory values, parameters are used: platelet count, fibrin markers, prothrombin time prolongation, and fibrinogen level, and different points are given for the different values, laboratory value of different parameters. And if the total is between 0 to 4, she does not have DIC. If it is between 5 to 8, then DIC is probable, and we may require a repeat of the score. Sometimes unnecessary, because of the wrong diagnosis of DIC, we may give many units of blood, and patient may develop complications because of the blood transfusion rather than the DIC. If she is admitted in HDU, then we may prevent from such type of complications, and even we may prevent from the unnecessary blood transfusion. Again, sepsis, lot of changes are there, but why it is important? Because puerperal sepsis account for 10 to 12% of the maternal deaths, and the day by day incidence increases, maybe because of the older maternal age, maybe because of the increased incidence of GDM, maybe because of the increased incidence of obesity and environmental problem. And as per the WHO, if patient develops septic shock, then mortality is between 50 to 60%, very high mortality. Again, management is changed. Now we are using SOFA score, definition is changed, and these are the causes in obstetric for the common causes for the sepsis, and these are the concurrent infections can lead to sepsis. And now we know that the disease progression is very fast when patient is having sepsis, and we may lose patient just because of the delayed management, and therefore such patients require admission in obstetric HDU, and we require to manage by septic bundle. We require to monitor 5-6 variables: mental health, heart rate, systolic, diastolic BP, respiratory rates, temperature, urine output. And for that we require, there is a bundle, septic bundle, 1 hour, 3 hours, 6 hours, which is not possible to manage in routine floor, and we need to give high oxygen flow, IV fluid resuscitation, blood culture, higher antibiotic. We need serum lactate level and accurate urine output monitoring. So, and in spite of all this, 50% of patients having sepsis with hypotension require vasopressor, inotropic support, which cannot be possible to manage in routine floor, and we require admission in HDU. So I will not go in, and it can lead to many complications. Again, ART pregnancy, day by day incidence of infertility increases. 1 in every 10 women in India has PCOS. Now there are 25 million Indian women suffering from endometriosis. ART can lead to many other complications. We all know that: critical OHSS, elderly pregnancy, multiple pregnancy, interventional procedures, increased incidence of cesarean section, and all this can lead to more complications, and patient may require admission in HDU. Again, GDM incidence increases to 3 to 7%, and when HbA1c is more than 11%, then fetal anomaly risk is as high as 25%. India is the capital of GDM. So we need, and when GDM can lead to many complications, I will not go in the list of complications, but we need insulin drip sometimes. We need close glucose monitoring. We may need multidisciplinary teamwork, and this is not possible in floor. So again, obesity increases. Similarly, increase in viral infection. Now H1N1 increase, COVID increase, chickenpox increase. So again, cardiac problem after direct causes of mortality, it is number 1 indirect cause of mortality. Peripartum myocardiopathy, it is observed that 2/3 of the maternal deaths because of cardiac problem are because of the peripartum cardiomyopathy. It's a diagnosis of exclusion, and early diagnosis can save many mothers from the mortality. Again, deep vein thrombosis, very high index of suspicion is important, and we may require heparin, and it is better if patient is on heparin if we admit such patients in HDU. And now again, postpartum psychiatric disorders are also increases. India is country having the highest number of teenage pregnancies. So again, it can lead to many complications. And CPR, total guideline, lots of changes are there in CPR, and we require such patients. And now lot of conditions, environmental factors, which can lead to many complications like preterm delivery, infertility, breast cancer, PCOS, mental disorders, so many things. And at the end, again, these are the changes. Hypothyroidism is like an epidemic. Now, alcohol consumption in India increased by 15%. So all these things can lead to high-risk pregnancy. And these are the patients may develop 2 minutes, hemodynamic instability, respiratory dysfunction, neurological complications, acute kidney failure, hematological complications, may require single organ support. All these patients require, when they have such type of complications, require admission in obstetric HDU. And these are the situations we are routinely facing in our practice. These patients require certain type of monitoring and certain type of care. They require infusion pump, syringe pump, equipments for monitoring. They require crash carts. They require central oxygen support. They require ultrasound with color Doppler, CTG machine. And if they require cardiac arrest or collapse, they may require BiPAP, defibrillator, AED ventilators. All are there in HDU, ICU, and which is not available in floor. So, and these are the patients managed as per the guideline and protocols which are displayed in obstetric HDU, and that is why if we admit such patients in HDU, we can manage them better and we can save those morbidity and mortality. Thank you very much for your patient hearing. Thanks a lot for giving me this. Thank you.
Thank you very much, sir, for the elaborate need. You have given almost all the indications of obstetrics for admitting the patient in HDU. And it is a need of the hour for all the obstetric practitioners to have the HDU in their set up so that the complications can be detected early and can be treated efficiently. Thank you so much, sir.
Thank you.
Any questions? Yeah.
So actually, in our society, we are having a lot of small maternity nursing homes, sir. We are actually planning, and it's in the process, to start our own HTU, which is going to be monitored by anesthetists, a team of anesthetists round the clock. So maybe in a year's time, it is going to be a thing, because shifting the patient 10 to 15 kilometers after an emergency is so difficult. And so we are planning to have a 10 HTU bed very near to our place. So that's why we got interested in this topic. Thank you.
May I request Dr. M.C. Patel, sir, to honor our chairpersons?
Alpesh Gandhi, sir, in the COVID time, you did an amazing job, sir. He was able to communicate with all the societies through Zoom platform, and you used it very, very well for us. Photograph. Charmila, மேல வரீங்களா? சின்மயி எல்லாம் மேல.
I request Dr. Saraswati ma'am to felicitate Dr. Chinmayi Ratha ma'am.
Was the founder of Cox, because you only recognize Cox, and we are very happy and to thank you very much on this day, sir. Because of you, we are here. Otherwise, we would not be here. Thank you very much.
Yes, sir, we sincerely thank you for the support. Everybody used to create a scare of Foxy, the Foxy, like that they will say. But in reality, when we go near, they are such friendly people. And the team of Foxy, which has been here since last 2 days, goes to show that even a small society can communicate with Foxy and do the things which we want. Thank you so much, sir.
I would like to thank Dr. Umayal, Dr. Chakravarti sir, and the team for giving us this opportunity to be a part of this excellent program. Thank you.
Thank you.
To chair our next session. From MMC, vast experience for 30 years in government service in various designations. Overseas service in MOH King, ranker first, second, and third MBBS gold medalist in anatomy, biochemistry, and microbiology, and completed his general MS General Surgery and MCS Surgical Oncology, and secured first rank in MCH. 2013, Dr. Sneklata endowed gold medal. Welcome, sir.
Thank you very much, ma'am, for this nice opportunity. So I think we have, first we have a capsule talk by Dr. Idayalya Ravi, who studied MBBS at SRMC. She is currently a postgraduate in obstetrics and gynecology in Balaji Medical College and Hospital. She has secured the second prize in the poster competition conducted by the Indian Medical Association. She is interested in high-risk obstetrics. Welcome, doctor.
Good afternoon to everyone present here. I'm Dr. Idalya, and I'm going to be presenting a capsule on cryotherapy in gynecology. So contents, we're going to be looking about the history of cryotherapy, principle, the equipments we use, indications, contraindications, side effects and complications, results of the treatment, and conclusion. History, cryosurgery it's a destructive technique that was introduced to gynecology in the late 1960s to treat cervical intraepithelial neoplasia. Therapeutic use of cold temperature has existed for a long time in the medical setting, first and foremost for its anesthetizing effects, but the damage that cold can do has also been noted from the earliest times. The first successful treatment of malignant diseases using cold were reported in England between 1845 and 1851 by James Arnott, who used iced saline solutions at temperature of minus 180 to minus 240 degrees Celsius to treat advanced breast and uterine cancer. Cryosurgery was first reported to be used in the therapy of cervical intraepithelial neoplasia by CRISP. So the principles, cryosurgery involves cooling of tissues that is less than 20 degrees Celsius until cryonecrosis occurs, and this occurs by crystallizing intracellular water. So the technique we use is the double freeze technique, that is the freeze-thaw freeze technique, which involves a 3-minute freeze followed by a 5-minute thaw with a repeat 3-minute freeze. The thaw period between the two freezing episodes will allow the damaged tissues from the first freeze to become edematous and swell with the intracellular fluid. So with this, when we go for the second freeze, the edematous cellular architecture is refrozen and extends the damaged area slightly deeper into the tissue, in which an ice ball is formed, which is 5 mm beyond the edge of the probe, which is confirmed by colposcopy. In this first picture, you can see the ice ball formation. So when we use this technique, it destroys the cervical epithelium up to 7 millimeter margin distal to the probe. And the time required for this process is related to the pressure we use in the gas. So the higher the pressure, the faster the ice ball formation. Again, depending on if you want to treat large lesions, then multiple overlapping ice balls are required. The important advantage is the procedure can be done without anesthesia as an OPD procedure. So you have two zones, the lethal zone and the recovery zone. Lethal zone is the frozen area which is located between the cryoprobe tip, which is minus 65 to minus 75 degrees Celsius. And for the necrosis to happen, it should be at minus 20 degrees Celsius. So in the lethal zone, the tissues in this area will not be able to survive the freeze. So neoplasia in this zone is readily destroyed by cryonecrosis. What is a recovery zone? A recovery zone is a tissue which is temporarily frozen at minus 20 degrees Celsius during the procedure, but this area will remain viable even after defrosting. And that is represented by the peripheral 2 millimeter rim of frozen tissue adjoining the leading margin of the ice ball. Now, after cryotherapy, a large central HPV load will be debulked, and the immune system may now be able to eradicate a limited amount of surrounding low-grade residual disease. Healing after cryotherapy takes around 4 to 5 weeks because the damaged tissue will slowly slough and it's replaced by the new cervical epithelium. Cervix can heal well and sometimes is a characteristic appearance of a radial ridging. The squamocolumnar junction is found to be lying just within the external os. The process is associated with a profuse watery discharge, which is often mixed with a necrotic cellular debris, and the healing process is complete within 2 months. You can do a follow-up with pap smear, usually 12 weeks following the procedure. And HPV DNA test can also be done after 1 year. And if it's positive, you have to retreat it, but with a different technique. The equipments we use will be seeing cryosurgery. We have to use the carbon dioxide or nitrogen oxide as the coolant. Then you have a cryo gun. Then you have a pressure tank, and you have various sizes of cryo tips depending upon the lesion. Then you have vaginal speculum, colposcope, and a 3 to 5% acetic acid or vinegar, and vaginal wall retractors. So this is a picture of the technique being done, a freeze-thaw freeze technique with the ice ball formation. So you have a picture describing the probe, trigger, handle, grip. So what are the prerequisites we need to know before following this procedure? You should not have any suspicion of invasive cancer or glandular disease. The transformation zone should be completely visible before you plan a cryotherapy, and there should be no extension into the endocervix, and endocervical curettage should be negative. So indications, it is indicated for cervical, vaginal, endometrial and vulval lesions, benign conditions like recurrent cervicitis, cervical erosions, and pre-malignant indications will be CIN1 to CIN2, and it's probably best reserved for small size lesions, and you can even go for low-grade squamous intraepithelial lesion. So coming to cervix, we have the International Agency for Research in Cancer states that cryosurgery can be used in treatment of CIN provided the following criteria are met. That is, as we already said, the lesion should be confined to the ectocervix, and there should be no extension to the endocervix or vagina. And the lesion should be completely visible, and it should not extend beyond 2 to 3 millimeter into the cervical canal. And there should be no evidence of invasive cancer, and lesion should be completely covered by the largest available cryoprobe tip of 25 mm diameter. Coming to vagina, indications for using vagina, it's actually not a popular method for treating vaginal epithelial neoplasia. A single freeze-thaw cycle can be used with ice ball formation, extending up to 3 mm of colposcopically normal epithelium. In vulva, you have the vulval intraepithelial lesion, less than 2 cm in diameter, can be treated by this technique, cryosurgery. And it can be used as a palliative therapy in case of recurrent fungating cancer of vulva and perineum. It can be used on vulva to eradicate small warts, and it can also be it's also been used to treat urethral prolapse. The method is extremely effective in producing complete annular necrosis and healing of this prolapsed tissue. Cryoablation in endometrium, so it can be used even for endometrial destruction. So you have to insert it into the uterine cavity, and you do a transabdominal sonography to confirm the location and the placement of the probe, and you follow the same technique of ice ball formation which happens during the cycle. So this will help in, it's an effective therapeutic option in cases of menorrhagia. So what are the conditions in which you should not use cryotherapy is that if you have presence of active vulvitis, vaginitis, cervicitis, in any inflammatory diseases, cervical cancer, in utero DES exposure, menstruation, if they're menstruating you're not supposed to do, and if the colposcopy is unsatisfactory, and a positive endocervical curettage. Also, if the lesions involve more than 2 cervical quadrants in size, again cryotherapy cannot be used, and lesions greater than 3 cm in diameter, lesions which extend more than 5 mm into the endocervical canal, any exophytic, nodular or papillary cervical lesions, low-grade CIN preceded by a cytology report of HSIL, discordance between review cytology, colposcopy and histology, CIN3, and even in HIV-positive women with cervical intraepithelial neoplasia, and after any previous failed therapy. So complications for following this cryotherapy, the patient will come to you with complaints of pain and cramping. Profuse watery discharge is the main complication, and you have to reassure them. It will be there for around 2 to 3 weeks following the procedure, and very rarely 1 to 4% of patients will develop cervical stenosis. Vasovagal episodes, infection and bleeding are also common. For some women, cervical anatomy can be changed after cryosurgery, and the squamo-columnar junction may not be visible because it would have moved into the cervical canal. So the results, so for cryotherapy, 94% cure rate is there for CIN1 and 93% for CIN2. So I would like to conclude that modern cryosurgery achieves efficiency and effectiveness through good, uncomplicated surgical results, a high cure rate, and a high quality of life for the patients. The power of cold needs to be understood and accepted by both surgeons. At present, cryosurgery of the cervix has lost ground to loop excisional procedures like large loop excision of transformation zone, large loop electrosurgical excision procedure, which can also be performed as an outpatient basis and provides a good specimen for histology. Thank you.
Thank you, doctor. That was a very lucid talk. So any questions from the audience? Okay, if there are no, can I just, you, okay, I think we have the questions at the end of the session, it seems, I'm sorry. So we'll reserve it and we'll call you back again.
Thank you. Thank you, Dr. Dalia, for your nice and crisp presentation. Next, I feel honored to invite our Oxy President, Dr. Premalata ma'am, to the stage to give a talk on tumor markers in gynec cancer. Which one speaks the truth? I request Padmavati madam to introduce her.
Hello, madam. At the outset, I would like to, I'm very happy to share this session with this energetic Dr. Sujay, the surgical oncologist. And I'm very happy to introduce Premalata madam. She is the President Oxy 2022, and she is the Consultant Head Academics Department of ONG at Dr. Mehta's Hospital, Chennai, former Director in charge of IOG, Chennai, former Professor Department of ONG, MMC, Chennai, presented papers in national and international conferences, expertise in tubal microsurgery. Actually, I got my training in tubal microsurgery under Madam in KMC.
Thank you, Madam.
Then recipient of Lifetime Achievement Award by
Thank
Dr.
you,
MGR Medical University 2012.
Thank you,
Over
Madam.
to you, Madam.
At the outset, I thank Dr. Umayal, Kanjipuram Gynec Society, Dr. Chakravarti sir for giving me an opportunity to be here today. And I'm given the topic of tumor markers in gynec cancer, which one speaks the truth. So to say we all know gynec cancer, endometrial cancer, ovarian cancer are all more increased in the older age group, especially in the postmenopausal women. And ovarian cancer are always detected in the late stage because of the difficulty in diagnosis. And accurate diagnosis of and proper monitoring of the disease needs once you have a proper diagnosis and management, you have a successful and good outcome. So currently a multimodal approach combining the evaluation of serum markers with imaging techniques are useful in order to have early diagnosis for a better prognosis and to prevent recurrence and for long-term follow-up. Currently, a lot of research being done on tumor markers because they being non-invasive, much effort is being done on research of tumor markers. So what are tumor markers? Tumor markers are either produced by tumor or by the body in response to tumors. These cancer biomarkers are the biological molecules, the presence of which says that the disease is present. These biomarkers typically differentiate an affected person from a non-affected person, and they are mainly due to alteration due to germline or somatic mutation, transcriptional changes, where the DNA to RNA changes, these all will be manifested as tumor markers. And there is tremendous variety of biomarkers like proteins, enzymes, and antibodies, and various peptides are among other categories. And nowadays we have a collection of alteration because of the altered gene expression. We have a set of proteins, proteomic molecules, and metabolomic. That means the analysis of metabolites in the biological fluids, which are all used as tumor marker. So currently, the tumor markers which we are currently using is mainly oncofetal antigens, alpha fetoprotein, and carcin embryonic antigens, hormones like HCG, glycoproteins, CA125, and other glycoproteins which are used as CA1, 15-13, 15-3, CA19-9, CA72-4, enzymes like LDH. So these are the common tumor markers which we are using for gynec cancer. And these tumor markers are mainly used for screening healthy population and for early detection of cancer, diagnostic confirmation of masses, and for prognosis and prediction of the therapeutic response. And these tumor markers are helpful in monitoring the disease and for finding out the early recurrence. So when it comes to the ovarian cancer, which is we all know, have three types, either epithelial ovarian cancer, germ cell tumors, and stromal cell tumors. And the epithelial ovarian tumor contributes 90% of the ovarian cancer, and both high-grade, low-grade serous tumors, endometrioid tumors, and all these have CA125 and HE4, which are the common tumor markers which were studied. And in mucinous tumors, CEA and CA19-9, the tumor markers which are being studied. So when you have a tumor markers, the first thing, serum tumor marker for epithelial ovarian cancer, which was introduced in USA was in 1965, that is CEA. And 1981, CA125 was introduced. And 2008, HE4 was introduced in USA. OVA1 is a 5-protein molecule biomarker panel, which includes CA125 and other inflammatory and transport proteins, which came into vogue in around 2009, Roma, which we have talked now, which includes CA125 and HE4. So these various panels were being introduced in the market periodically. So which is more useful? Actually, CA125 is the only tumor markers extensively used and has been followed up. As we all know, it is a glycoprotein which is being produced by the coelomic epithelium during embryologic development. So it is expressed by all the cells, almost the mesothelial cells of the pleura, pericardium, and the peritoneum, as well as the tubal, endometrial, and endocervical tissues. Because of that, it is expressed not only in ovarian cancer, but also in adenocarcinoma of cervix, endometrial adenocarcinoma, GIT carcinoma, and breast cancer. The CA125 at the premenopausal women, the cutoff is around 50, whereas postmenopausal it is around 35 is found to be normal, upper limit of the normal. So why CA125 is very much important? Because the rising level was found even 5 years prior to the development of diagnosis of cancer, ovarian cancer. So this principle was tried, was crucial in application for screening asymptomatic women. CA125 is elevated in 82% of the non-mucinous tumors. In the slides, okay. CA125 is elevated in 82% of the non-mucinous epithelial tumors. But the main problem with the CA125 is in early tumors, in stage 1, only 50% is found to be elevated. So having a low sensitivity. Whereas in advanced cancers like a stage 2 to 4, it is raised in more than 90% of the cases. More than 1,000 international units are found in advanced cancers. So is there any role for ovarian cancer screening by CA125 as a sole agent, as an independent screening marker? Is it useful? As I told earlier, has a low sensitivity because in stage 1 cancer, only 50% is found to be elevated. And specificity is lower because apart from ovarian cancer, in other non-ovarian gynecological cancer also, it is increased, endometrial cancer, endocervical adenocarcinoma. So low specificity. And it is raised in benign conditions like endometriosis, fibroids, adenomyosis, and other benign masses. And non-gynecological conditions like heart failure, pancreatitis, and hepatitis, it has been found to be raised. So it has low specificity and low sensitivity, because of which CA125 as such, as an independent screening agent for healthy population to diagnose endometrial ovarian cancer is not found to be useful. And also comparing to the premenopausal, postmenopausal women, it has been found to be sensitive, higher sensitivity in postmenopausal compared to premenopausal women. So, but as a first line test, you do a CA125, and a second line test, if you are doing a ultrasonogram, it has been found to be having increased sensitivity specificity. This led on to the ROCA test, which is used for screening. So what is a ROCA test? ROCA test is a test which combines one's age, menopausal status, risk factors, and serial blood measurement of the CA125. So serially the blood measurement of the CA125 was done, and whenever you have the second line, when there is in the serial measurement, it's not a single level, when the women are developing ovarian cancer, there will be a raise of a CA125 from the baseline level following a change point. This change point profile was used as a basis for ROCA. So the ROCA was introduced, which in a case of benign tumor, what happened, the CA125 will be raised, but it will be sustained elevated, but it will not be elevating continuously. So the change point profile was used for categorizing women as low risk, intermediate, and high risk. So this ROCA test basis was tried in various screening trials. What was the trial? The UK collaborative trial of ovarian cancer screening, NIH, prostate, lung, colorectal. But among this, the UK collaborative trial, which involved more than 2 lakhs women, the ROCA basis was used. Multimodal screening procedure. But they told ROCA may have a role in detecting early cancer, however, further follow-up is needed. So what is this trial? In this trial, 2 lakh women were included, 50% were control, and one arm having only ultrasonogram. TVS was used. Another thing, you have a multimodal screening. In the multimodal screening, initially they have a CA125 and they are categorized as a low, medium, and intermediate. If it is a low, annually they did a repeat screening. But if it is going to be intermediately, you have to repeat it every 12 weeks. And if it is elevated, you have to combine with the with the ultrasonogram. But ultimately, the screening, this trial which went on till 14 years, they said, though it can detect early cancer, it has a non-significant reduction in ovarian cancer mortality, apparently only after 7 to 14 years. And they said, at present, it becomes unclear whether the benefits of screening outweigh the risk. If the patient has been done an ultrasonogram and they found to have a false positive result going for an invasive procedure. So it was not clear by this trial. So ultimately the authors concluded that further follow-up is required. So as a screening modality, CA125 has not found to be definitely useful. And coming to the role in diagnosis, when an adnexal mass, what is the role of CA125? So CA125, as we were told earlier, it has, as a diagnostic molecule, it has a low sensitivity because it has been influenced by, and also low specificity because it is influenced by other cancer-related factors. Thereby, the risk of malignancy index, RMI, came into vogue in 1990 by Jacobs, he developed. So as we all know, RMI includes 3 factors, score of ultrasonography, menopausal status, and CA125. So you have in the ultrasound, we have 1 point for 4 scores, multilocular cysts, solid areas, metastasis, ascites, and bilateral lesion. And for menopausal, 1 for premenopausal, 3 for postmenopausal, and CA125 innate. So there were RMI 1, 2, 3, 4. In the 4 only, the size of the tumor mass was taken. But ultimately, they said RMI 1 is found to be more reliable and validated. And what does a nice guideline say? When you do an RMI and the cutoff is taken as 200, the sensitivity is around 78% and specificity is 87%. There are some centers where they take the upper limit to be 250 with the lowest sensitivity but higher specificity. But this is applicable only to non-mucinous tumors. So comparing this, the RCOG guideline says if you have a score less than 200, it can be treated in a general gynecological unit. So you have an adnexal mass, you put a RMI, if it is less than 200, as a gynecologist, you can put a laparoscopy, that was a guideline. But if it is more than 200 or 250, you need further modality of screening by CT, MRI, referral to your oncosurgeon, and needs a full laparotomy and staging procedure. So what is the risk of malignancy real? When you have an RMI index of less than 25, they found the risk of cancer is less than 3%. When it is greater than 250, the risk is around 75%. So ultimately, the use of RMI has a higher sensitivity of 87% and specificity of 97% ovarian cancer. So as a tumor marker, CA125 along with other factors is found to be useful for diagnostic purpose. So next comes the HD4. HE4, which is another protein biomarker, which has been found to be more sensitive because it is found elevated even in early stages and not elevated in benign conditions. And it has been found to be expressed in both early and recurrent carcinoma. Thereby, but in the case of HE4, in premenopausal women, the cutoff is 70. Unlike CA125, where the cutoff in the postmenopausal is low, HE4 in the postmenopausal women, the cutoff level is high. So they have a premenopausal, the value of HE4 is low. Postmenopausal women, value is high. So they compared whether CA125 and HE4 in case of detecting the presence of cancer. They found HE4 has more specificity as compared to CA125, but sensitivity are same. So then came the ROMA. What is a ROMA? They tried, when I combined HE4 and CA125, the detection rate is found to be higher. So they made the ROMA score, which is a quantitative test, including CA125, HE4, and menopausal state. It tells the predicted probability, but has a very complicated graph for a low risk for premenopausal and postmenopausal in percentage has been done. So overall, the ROMA has highest sensitivity and negative predictive value. And when various studies are found, it has been found that one study, Van Gorford, found HE4 nor RMO predicted well, does not perform well than that of a CA125. They said it is not doing well. Whereas the other study said HE4 and CA125 combination had detected overall survival rate very well. compared to CA125. So the studies were all in a meta-analysis, they found various changes. They were not uniformly favoring the Roma. And also the RCOG says you have specific assays needed for HVO4. So routine use is impracticable for including Roma for algorithm for the detection of ovarian cancer. So for diagnosis, it has not been found to be definitely useful, but it has been tried in various situations. So what is the role of CA125 in prognosis? Definitely it is as a prognostic factor, it has been found to be useful because when the CA125 level is demonstrated to strongly predict the overall survival and progression-free survival rate compared to the other, in a case of ovarian cancer. When the patient is on treatment, decline in the value of CA125 to 50% shows it's a good response. When the value is raised, it means chemo-resistant disease. And in recurrent disease, definitely 90% CA125 is found to be raised. And the CA125 is found to be raised even before the onset of clinical symptoms in a case of recurrence. Both before physical and clinical symptoms of recurrence, CA125 was found to be raised. So when treatment was applied, done on the level of CA125 alone, before the clinical symptomatology in case of recurrence, they didn't find any significant survival benefit. So they have to wait for the symptoms of clinical symptoms. So overall, though it does not have a survival benefit, it's definitely useful as a prognostic factor, and current guidelines say CA125 remains the gold standard for follow-up of epithelial ovarian cancer. Coming to the mucinous tumors, we all know CEA and CA99 are the two tumor markers which have been useful. And we all know CEA is elevated even in other gastrointestinal malignancy. So it is elevated in borderline mucinous tumors and also in Brenner tumors. But because it is mainly secreted by the gastrointestinal malignancy, it is useful to differentiate secondary deposit from GIT malignancy or from the primary metastasis. So if the younger women with bilateral mass with the CEA is elevated so much that the CA125 CEA ratio is less than 25, it is more in favor of primary gastrointestinal malignancy. So in that way, it is found to be useful. So other tumor markers, just because they asked what are the tumor markers, you have Humpty number of tumor markers, CA125, all these are being studied elaborately. None has been found to be having definite higher sensitivity and specificity. The use of inhibin was mainly for mucinous epithelial tumors, and prolactin, osteopontin, kallikreins, mequins, vascular endothelial factor is now recently being studied, mesothelin and all. So this shows a complicated slide where the sensitivity, specificity are there. Some has higher sensitivity, lower specificity. So all these are having, none has a complete higher, sensitivity and specificity are more than 90%. So recent the ovarian cancer biomarkers, they say the expression of mesothelin is found to be correlated with chemotherapy. So they say recently mesothelin is found to be beneficial in follow-up. With all this, when you go through the literature, only two things, the vascular endothelial factor and mesothelin, they are using for cancer therapy in some of the cancer centers. These ROC curves were underneath the curve, more than 8, the biomarkers value, various have various values. And this led on to the study of panel approach for screening, because each has different. They tried OVA1 now, and then they tried now actually various panel approach were done, but none are found to be definitely useful. That is the thing. So newly emerging ovarian cancer biomarkers are there, which has been found to be all under research thing. So however, from the research to clinical side, lot of studies should be done. So we are now in the research thing. So I'll just do the guidelines. CA125 is the only serum marker which is used for primary evaluation of ovarian cancer, but it cannot be used alone. It has to be used along with the ultrasound marker as a RMI. There are no enough evidence to support the use of other other markers to assess the risk of malignancy in postmenopausal women. So germ cell tumors, we all know, we have a beta-HCG, LDH and AFB. These are the tumor markers. And these are elevated in advanced cancers. But in just like CA125, in stage 1 cancers, only 20% raised, so they cannot be used for screening, but only for prognostic. If it is very high level of AFB and very high level of HCG says the prognosis is poor and 5-hour survival rate is found to be less. And serum LDH is used as a follow-up where the tumor does not secrete AFB and alpha-fetoprotein. So that is for the RCOG guidelines saying all young women, that is women less than 40 years with adnexal mass, we have to do LDH, AFB and HCG should be done in the evaluation. And these tumor markers can be used for surveillance because the half-life as they go on decreasing. We have to follow the patient till the tumor markers level are found to be 0. But how long you have to continue the surveillance is not yet definitely known. So sex-cord stromal tumors to complete, estrogen, inhibin and 2 more minutes. Estrogen, total inhibin and anti-Mullerian hormone are used for, as they are tumor markers for sex-cord stromal tumors. Rather than estimation of estrogen, it is because of the effects of estrogen, the diagnosis was made, whereas total inhibin secretion is correlating with the tumor burden, and anti-Mullerian hormone combined with the inhibin is found to have a better diagnosis for germ cell tumors. And it has been found that AMH levels increase even 3 to 11 months before the recurrence. So it has been found to be useful for follow-up. Coming to the endometrial cancer, we never talk about tumor markers in endometrial cancer. For diagnosis, it is not useful, whereas it has been used for disease prognosis. In advanced cancer, CA125 is found to be increased. It is correlated with the local metastasis, lymph node enlargement, and carcinomatous implants. So people are using, at the evaluation, at the time of diagnosis, you see a CA125, and during follow-up, they do a CA125. And the levels, if they are very high, they are associated with poor prognosis. The HE4 also has been used as a reliable marker for endometrial cancer, and it has been found to be elevated even in early stage, but it has not been associated with, they have not found the definite correlation with lymph node enlargement. But these 2 things have been just done for follow-up. So cervical cancer biomarker, just for completion, people have talked about squamous cell carcinoma antigen, CA19-9, CEA. These are the tumor markers which has been tried for cervical cancer and for follow-up therapy. And recently the vascular endothelial growth factor, which has been correlated definitely with the staging of cancer and by the disease, it is correlated with the disease recurrence. So people have tried to do vascular endothelial factor and keratin, cytokeratin 19, that is CIFRA, all combined together. They are trying to evaluate the significance of early diagnosis recurrence, but everything is under research, large study is needed. Vulvar cancer also, SCC antigen is being tried. HCG, I'm not going to talk, we all know it has been a definite tumor marker for gestational trophoblastic neoplasia. So to summarize the key points, serum tumor markers have a pivotal role in screening, differential diagnosis, prognosis, management, and surveillance of gynecological cancers. Ideal screening should have a good specificity and sensitivity so that a false positive does not lead the patient to a invasive medical intervention like surgery. CA125 can be used to identify adnexal mass with a high risk of malignancy, but it can be elevated even in benign conditions. It is found to be reliable to follow-up of malignant ovarian tumor for thing. HE4 has demonstrated higher sensitivity and specificity, but the assay is needing little more. They have the assay should be standardized in each lab, particularly, but HE4 in combination with CA125 is found to be useful. Alpha-fetoprotein, HCG and LDH are useful for diagnosis and surveillance of germ cell tumors. CEA and CA99 are primary gastrointestinal markers, and it helps to differentiate primary metastatic disease from the secondaries from the GIT. To conclude, single value or test is unreliable in itself. No perfect serum marker has been identified. No single markers greater clinical value or consistency than CA125 so far. It is noteworthy that many situations, elevations of markers in non-malignant diseases are often transient, whereas in a case of malignant disease, usually the elevations are associated with, they remain constant or consistently they rise. Ordering serial testing of tumor markers can help detect falsely elevated levels due to transient elevation. The development of newer markers and their evaluation will continue, as will the search for the ideal tumor marker. Novel markers using proteomics and nanotechnology has the potential to both detect disease and recognize individualization under the hope of the future. Cell-free DNA have been identified as a potential target for screening an aberrant mutation or methylation patterns of normal cellular and tumor-derived DNA, and they have been identified in gynecologic cancers via serologic or liquid-based cytologic testing. MicroRNA and cell-free DNA may serve as potential targets for new tumor markers that can aid in diagnosis of gynecological disease. Thank you.
Thank you very much, madam, on your elaborative and informative talk on this topic of gynecological cancers, with a concluded note of a single test is not very reliable, and we have a long way to go. Thank you, madam.
Thank you, Premalata ma'am, for giving an insight about various tumor markers used in gynec cancer and emphasizing the usefulness of CA-125 for scoring ovarian tumor. Thank you, ma'am. I request Dr. A. Preeti to give an overview about ovarian cancer. Epidemiology, diagnosis and treatment. Welcome you, ma'am. I request Dr. Sujay to introduce Dr. Preeti.
So it's a proud privilege to welcome Dr. Preeti here. She works with me at Kaveri Hospital. She's completed her MBBS from Madras Medical College. She's done her post-graduation in MD Radiation from the Madras Medical College again, and then she completed her DM Medical Oncology from Madras Medical College and RGGH again. So we'll move on to the topic. Thank you, Dr.
Thank you, sir. Good afternoon to one and all. I thank the organizers for giving me this opportunity to give a talk on the overview of ovarian cancers. Slides. Today my talk will be over the topics introduction, pathophysiology, clinical presentation and treatment. Initially, let's talk about the epidemiology and the risk factors. Ovarian cancer is the 8th most common cancer amongst females over the entire world. As we can see in the graph, breast cancer remains to be the most common cancer amongst females, followed by colorectal, lung, cervix, thyroid, endometrium, stomach, and followed by ovarian cancer. It is one of the leading causes of cancer mortality amongst women. It is the 7th highest rate of mortality and the 8th highest number of cancer-related deaths worldwide. So in this Indian scenario, it is estimated to increase to 3,71,000 a year by 2035, 55%, and while the death rate increases by 67% to 2,54,000. And there are several risk factors associated with ovarian cancers, which includes family history, first degree relative with ovarian cancer, reproductive history, early menstruation, fewer pregnancies, late menopause, and genetic predisposition, mutations in the DNA damage repair, which includes BRCA genes, BRCA1 and 2, and HRD, obesity, and increasing age. It is highest in women in the age group 55 to 64 years, and the median age is 63 years. Next, we shall move on to pathophysiology, which involves anatomy, physiology, and pathology. As we all know, ovarian cancer develops from 3 main cells: epithelial, germ cell, and stromal cells. The most common tumor, ovarian tumor, is epithelial tumors, which accounts for 90% of all the ovarian tumors. Amongst this, 71% is high-grade serous tumors, which is followed by low-grade serous clear cell carcinoma, endometrioid, mucinous, undifferentiated, and Brenner's. Stromal cell tumors account for 5%. It is usually diagnosed in the stage 1 and is treated with surgery alone. And main subtypes include granulosa cell, granulosa theca, and Sertoli Leydig cells. Germ cell tumors account for about 5%, and most common subtypes include teratoma, dysgerminoma, endodermal sinus tumors, choriocarcinomas, and embryonal. So high-grade serous carcinomas are most common type in epithelial ovarian tumors. As we had discussed earlier, high-grade serous carcinoma is the most common, accounting for 71%. So amongst the high-grade serous ovarian cancers, half of high-grade serous ovarian cancers harbor defects in the homologous recombination. This is important in the mutation, in the molecular point of view, because patients with homologous recombination deficiency will respond to PARP inhibitors, which can be used in the maintenance setting. So this includes BRCA genes and many more other gene mutations, and it occupies almost half of all the high-grade serous ovarian cancers. Next, we shall be dealing with clinical presentation, diagnosis, and BRCA testing. So how do we diagnose ovarian cancer? Patient can present with several symptoms, which includes abdominal distension, abdominal pain, vaginal discharge, vaginal bleeding, bowel and bladder disturbances, diarrhea, fatigue, loss of appetite, loss of weight, urinary frequencies. Symptoms of advanced diseases might include increased abdominal girth, bloating, nausea, anorexia, and symptoms which can mean metastasis like respiratory symptoms, difficulty in eating, abdominal or nodal mass, pleural effusions, anorexia, etc. How is this diagnosed? It includes physical exam, imaging, as well as tumor markers evaluation. So physical examination involves the detection of ascites and pelvic examination. Imaging, which includes transvaginal ultrasound, abdominal ultrasound, CT or MRI scan, and tumor markers, which include CA-125. So there is currently no reliable screening test to detect any ovarian cancers, but two main tests which can be used in cases of patients with with mutations that are those patients who are susceptible to this type of tumor. We can use a transvaginal ultrasound and CA-125 blood tests. If the ovarian cancer is detected early, then it can be easily treated. Hence, screening can be done in cases where the mutation is present. If an ovarian cancer is suspected, then a sample of the suspected tumor is required for diagnosis and treatment. So the main techniques include image-guided biopsy, laparoscopy, laparotomy, removal of abdominal fluid, and chest X-rays. If an upfront surgery is possible, then we go ahead with a upfront surgery, which includes a staging laparotomy. Then the treatment follows is adjuvant chemotherapy followed by maintenance therapy. But if the upfront surgery is not possible, then an image-guided biopsy is mandatory, following which a neoadjuvant chemotherapy is given to shrink the tumor and make it operable, and then we take the patient up for surgery, cytoreduction, and then followed by adjuvant chemotherapy and maintenance therapy. So following the confirmation of ovarian cancer, the staging has to be done. FIGO staging and TNM stagings are there, and grading also helps to recommend certain treatment options. So there are 4 stages. Stage 1 includes tumor is confined to the ovaries, and stage 1C includes the positive washings. The stage 2 includes the tumor which spreads to the uterus or the fallopian tube and to the intraperitoneal pelvic tissues. And stage 3 involves extraperitoneal pelvic organs, pelvic tissues, and retroperitoneal lymph node involvement. Stage 4 involves distal metastasis. BRCA genes has very great implications in clinical practice, because it can identify those who are more sensitive to subsequent chemotherapy-based treatments and can be suitable for targeted therapies. It has a very good prognostic effect, and it is a most important prognostic indicator alongside stage at diagnosis, histology, and extent of surgical debulking. And it also helps to identify women at increased risk for ovarian and breast cancer and at high-risk family members, and allow consideration of preventive strategies. So when to test for BRCA? It is recommended by most of the guidelines in most of the countries that it has to be done at diagnosis. Because if it is done at diagnosis, then we can easily identify the patients who will respond to the further treatment post the surgery, and it also acts as a very good prognostic indicator. So we can also identify the family members at risk, and we can implement the screening protocols for those patients so that we can detect the tumor earlier. Ovarian cancer diagnosis, the key steps involve a test is done. If it is positive, then clinical considerations, genetic counseling is done, and the BRCA1 or 2 germline test is done if in a family member. And if the patient is found to be positive, then if the family member is found to be positive, then they go ahead with the genetic counseling and the family considerations can be done. So samples collected at cytoreduction surgery can be used for genetic testing, including germline as well as somatic BRCA testings. Next, we shall move on to the treatment management. So it's quite clear-cut, like we had mentioned earlier. For stage 1 ovarian cancers, upfront surgery, usually laparotomy is done. TAH, BSO or USO can be considered. And if it is stage 1 or stage 1A or B, then it's observation or platinum-based chemotherapy based on the stage and based on the grade as well as the histology. And stage 1C is followed up by platinum-based chemotherapy plus or minus bevacizumab. Stages 2 to 4, if the patient is fit for upfront surgery, then we go ahead with cytoreductive surgery followed by adjuvant chemotherapy. If the patient is not fit for surgery, then post image-guided biopsy, we go ahead with the neoadjuvant chemotherapy. Then make the tumor operable, then proceed with the cytoreductive surgery followed by adjuvant chemotherapy. Maintenance therapy is given as appropriate, and then the patient is monitored. If there is any recurrent disease, then systemic therapy can be given and followed up by maintenance or observation. So there are different classifications of recurrent ovarian carcinomas. There's platinum sensitive, platinum resistant, and platinum refractory. Platinum sensitive, the cancer recurs more than 6 months after completion of initial platinum-based chemotherapy. Platinum resistant recurs within 6 months, and platinum refractory progresses during the initial chemotherapy without clinical benefit. These are the NCCN guidelines. Like we had discussed post-surgery and stage 2 to 4. If bevacizumab was used as part of the primary therapy, then it is used as part of the maintenance therapy as well. And based on the BRCA1 or 2 wild or somatic mutations, if the mutation is present and the patient has got CR or PR, then the maintenance therapy can include a PARP inhibitor also. So what are the rates of cure? Only 15% of stage 3 or 4 patients survive for 10 years post-diagnosis. This maintenance therapy can help to prolong survival. And the progression rates are also quite, 70% of the patients can relapse. So the maintenance therapy also shows benefit in this case. And the quality of life also has improved in these cases.